So welcome everyone to meeting number 41 of the House of Commons Standing Committee on Health. The committee is meeting today to study the Patented Medicine Price Review Board's guidelines. So I would like to welcome the witnesses. As an individual, we have appearing Dr. Stephen Morgan, Professor, School of Population and Public Health from the University of British Columbia. From Bio-Québec, we have Ms. Annie Perrault, Chief Executive Officer, Monsieur Paul Levesque, President et Chief Executive Officer, Inc. From Breast Cancer Action Quebec, we have Sharon Batt, co-founder, adjunct, Dalhousie University Department of Bioethics, and Ms. Jennifer Beeman, Executive Director. And with Cystic Fibrosis Canada, we have Kelly Grover, Chief Executive Officer. That being the case, I will now invite the witnesses to...
Point of order, Mr. Chair.
Ms. Sadu on a point of order.
This topic, encourage witnesses to complete a conflict of interest disclosure form. I understand some witnesses today may have already done so, but for anyone who may not have done so yet, I would ask them to do so as soon as possible with the clerk of the committee on whether a witness has an economic interest or in act as an officer or a director of any outside entity whose financial interest would reasonably appear to be affected by the addition of the witness testimony to any report that may be written by the committee on that matter. Witnesses should also disclose any personal, business, or volunteer affiliation that may give rise to a real or apparent conflict of interest. Thank you, Mr. Chair.
Thank you, Ms. Sadu. So we will carry on with statements from witnesses. I would invite, actually before we start, I'll advise witnesses that I have cards. A yellow card I will display when we're near the end of your time slot, and I will display a red card when your time is effectively up. If you see the red card, you don't have to stop instantly, but do try to wrap up. Thank you very much. So we'll start with Dr. Morgan. Dr. Morgan, please go ahead, 6 minutes.
Yeah, thank you very much, and I appreciate the opportunity to speak to you today. By way of introduction, I am an economist by training, and I am a full professor of health policy at the University of British Columbia. I think it's important to note, for instance, that I've published over 150 peer-reviewed research papers on pharmaceutical policy. I've won literally millions of dollars in peer-reviewed research grants in Canada and the United States. And I have served as an expert on expert advisory committees concerning matters related to pharmaceutical pricing and access for the World Health Organization and the OECD. I'll keep my opening remarks very brief, as I prefer to use the available time to help fill knowledge gaps that you might have identified as important to your work. I will only start by expressing my support for reforms to our patented medicine price regulations. The old regulations were never designed to provide significant protection against high prices in Canada. They were designed on the false premise that if Canada paid about the same amount for pharmaceuticals as countries with high levels of pharmaceutical R&D, then Canada would also become a country with high levels of pharmaceutical R&D. That was never going to happen, and sure enough, it didn't. As I wrote during the 10-year review of the PMPRB in 1997, there was much to fix in the regulations from their outset. But the need for regulatory reforms has become even greater in recent years. Two trends are important here. First, the pricing of pharmaceuticals has become entirely secretive worldwide. Drugs are priced like cars at a dealership. There is the list price, which everyone knows is higher than anyone should really pay. And then there is the actual price, negotiated in secrecy between the seller and each individual buyer. Paradoxically, it was the widespread use of international reference pricing regulations that was the main reason that secrecy has now become the norm in pharmaceutical pricing. That is, so many countries were using international comparisons of list prices to determine the maximum prices that should be charged within their countries, that manufacturers decided to go with confidential prices and confidential price negotiations as a means by which they could charge the most they can possibly do in every market. But in order to do that, they had to inflate, that is, raise list prices in every market. So the benchmarking of list prices to international comparisons is now the norm, and frankly, it is no longer enough. This brings up the second reason for regulatory modernization, and that is the excessive prices that are now frequently asked for many medicines, especially for medicines that are specialized drugs for treating serious conditions. Excessive patented drug prices are indeed possible because patents give manufacturers temporary monopolies over the sale of particular medicines. The potential for abuse of the resulting market power is high because consumers of patented medicines, also known as patients with medical needs, can suffer and might even die if they are unable to afford a treatment. By legally limiting the net of confidential rebate prices that a manufacturer can even ask the Canadian healthcare system to pay, new patented drug price regulations could prevent the worst cases of excessive pricing and at the same time speed up negotiations over final prices and the terms of coverage for Canadians. Patients would get the medicines they need more quickly, and our healthcare system, ideally a system with universal pharmacare incorporated within it, would likely be able to afford to cover more of those medicines. Now, industry will oppose these reforms, and they will provide funding to patient groups willing to oppose the reforms too. But that doesn't mean the regulations are wrong. If anything, it means, unlike the original 1987 versions of the PMPRB regulations, the proposed reforms might actually work. Thank you. I look forward to any questions you have.
Thank you, Professor. We go now to Bio-Quebec. Ms. Perreault, I presume. Go ahead, 6 minutes, please.
Merci. Thank you very much, Chair. Thank you, Mr. McKinnon. Thank you to all committee members for welcoming Bio-Quebec to take part in this very important discussion. I'm Annie Perreault. I am CEO of Bio-Quebec. Bio-Quebec is an industrial organization. It represents, in fact, over 150 organizations, which are Quebec businesses, biotech businesses in the R&D phase, contractual research businesses, clinical and preclinical research companies, as well as venture capital investors. We are present everywhere, end-to-end in innovation spectrum from research to marketing. We're here today because the proposed changes are really worrisome to us, and COVID-19 makes it worse. The PMPRB was created in the 80s with a limited oversight role in order to prevent the abuse of exclusive rights, that is, of patents. That's why it was created.
I was listening in French, and then I tried going to the English, and the level of sound both of the speaker and the translator are the same. So I don't know, for those who are listening in English, I don't know how and if you can hear what's being said.
Thank you, Mr. Pawlowski, on your point of order. I wonder if the clerk could just have a quick check with the translation booth to make sure we're all squared away.
Mr. Chair, it was fine on mine. I don't know if, Marcus, sometimes if you unplug your headset, plug it back in, it might help.
Yeah. Thank you. We will proceed. I apologize to the witness. Ms. Perreault, please proceed. Allez-y, s'il vous plaît.
Merci. As long as thank you for these 6 minutes. I'm gonna be fine. Thank you. L'encadrement du prix des Oversight of medication prices is a provincial responsibility. Provinces are responsible for healthcare, and in Quebec, we have a public pharmacare program. That means that we already have ways to set price controls like the PPA and as well negotiating product listing agreements. Innovation takes time, it takes resources, and a good head on your shoulders. It's a combination of financial risks, of corporate strategy, as well as scientific knowledge. Innovation can only happen in a stable, predictable context, which takes into account both the local markets and the global environment. And I would like to state that financial risks that our entrepreneurs take in biotech are much more substantial than in any other sector, because a biotech company and its financial partners, they invest in products for many years, in products and projects without knowing if the drugs that they are developing will even be profitable for them. And with the increase in precision medicine and targeted therapies, it's just as expensive to develop a new drug, but it's being developed for smaller and smaller groups of people, which increases risk for companies and investors. This whole delicate balance, its complex balance, would be upset by the changes. In our opinion, the new fee structure would deter investment. Furthermore, there would be jeopardization of innovative medication on the market, which would directly affect patients. And who would take this risk in this new context? In our opinion, the changes, the reform, it's misdirected and misguided. We're trying now in Canada to get out of a health crisis, which is showing us, in fact, how important it is that the government support the health sciences sector rather than slowing it down, which this reform would do. There couldn't be a worse time to destabilize the health innovation ecosystem. We need to stop these changes and maybe have a calm, cool-headed discussion in a few months. We also need to think about the PMPRB, of course, and we also need to think about the health sciences ecosystem, not only in the context of reforming medication prices, but also with a view to implementing a Canada-wide strategy for life sciences. Such a strategy should include research, innovation, economic development for all of Canada, as well as prioritizing the health of Canadians. The pandemic has taught us something very important. The health sector industry is developing vaccines. That gives us hope of having a normal life. It's a very promising sector for Canada, and we need to support it rather than the opposite. Here today with me is Paul Lévesque. He is president of Thea Technologies. It's a Quebec biotech business which developed, created, and marketed 2 medications for HIV carriers and is currently developing other cancer and liver disease drugs. Paul joined this company after 35 years of experience in the pharmaceutical industry. He has been innovating for 35 years. 28 of those years were spent at Pfizer. He spent half his career outside of Canada. He has taken on many roles in marketing and in management in Europe, Asia, and in the United States. And recently he worked in New York. This is very important to Paul and to me. Paul, over to you. Thank you, Annie, and thank you all for inviting me to join you today.
Form a firm. It is my role today to tell you that if this reform goes forward, it will contribute to delaying and reducing the amount of innovative therapies that will actually make it to Canada. I'm absolutely convinced of that. I sit in one of those seats, and I can assure you that this is what would happen. Now, how can I say that? Well, imagine for a moment that you have a Tesla at $100,000 a piece in the US, but at $50,000 a piece in Canada. That's what the reform is asking us to do. So an entrepreneur like me facing, just like the head of Tesla, would actually decide not to launch the Tesla in Canada anymore. That's what would happen because of cross-border trade, because of, the fact that it would put undue pressure on, the 2 markets. That's what this reform will do. So people sitting where I sit today will actually decide not to launch. Does that mean that we cannot reduce the price of pharmaceuticals in Canada? The answer is no. This is just the wrong reform for doing it. If you want to actually have lower price, you have to get to the negotiation table with provinces and actually find creative ways to reduce the price based on targeted population, based on performance, where pharma companies can actually make sure that we're held accountable for the performance of our medicines. The point is that What you have on the table now is the wrong reform to do whatever you want to do. So I just want to wrap up here. I'll be very happy to answer your questions. There are ways to actually bring innovative medicines at a good price in Canada. This is the wrong way. And I had a lot of ideas. We have not exhausted the ideas, but we have to get out of that box and find other solutions. Thank you very much.
Merci, Bio-Québec.
Thank you, Bio-Québec.
Breast Cancer Action Quebec. Ms. Sharon Batt, co-founder, please go ahead. 6 minutes, please.
Okay, thank you, Mr. Chairman and committee members, for inviting us to present at these hearings. 30 years ago, 4 of us started Canada's first breast cancer advocacy group because we believed in the potential of these groups to support and promote the needs of patients. Unfortunately, in the mid-1990s, the government withdrew funding from patient groups and many turned to the pharmaceutical industry for support. For the past 20 years, I've researched these partnerships, as have many others. A large body of evidence now exists to show they compromise the potential of groups to inform drug policy. The research shows that through financial support and social relationships, the industry has captured a large segment of the global patient advocacy movement. By captured, I mean it is starkly evident in the organizations that have intervened about the PMPRB regulations and guidelines. We believe the new PMPRB regulations and the proposed guidelines will be effective tools to cap the constant upward spiral of drug prices that prevents increasing numbers of patients from gaining access to needed drugs. Excessively high prices distort the allocation of health resources. They threaten the sustainability of healthcare systems on which all patients depend. At issue in these guidelines are the rules that determine whether many Canadians can afford to pay for their prescription drugs. Many reports over many decades have recognized that an effective universal healthcare plan must cover essential drugs, and recent polls show that 86% of Canadians support a national pharmacare plan. We're alarmed by the extent of opposition from pharma-funded patient groups to the PMPRB. Their voices are completely out of proportion to those of the independent patient groups, of the groups that work with low-income people, and other civil society groups that support a national, entirely public pharmacare program. When the PMPRB revised and weakened the first version of its guidelines, we were dismayed. Was this pullback based on evidence or on the intense lobbying by the industry and patient advocacy groups? Drug policy analysts in all countries recognize that the pharmaceutical industry is pricing new drugs at whatever the market will bear. Many of these expensive drugs don't improve patient survival or their quality of life. Some have been recalled because of the level of harm to patients. Patient advocacy groups have a responsibility to press for reforms that will limit these harms to patients and threats to our health system. This is hard if you're in a partnership relationship with an industry that benefits from high prices. This is why Breast Cancer Action Quebec will not accept any funding from pharmaceutical companies, nor do any of the groups or advocates with whom we collaborate. Canada needs transparency laws that would allow the public to examine the relationships the industry has cultivated with patient groups. We do know these relationships are extensive, not only in Canada, but in all high-income countries. The industry strategies used to cultivate patient advocates, dinners, media training, and unrestricted educational grants have been used for decades to cultivate physicians. They work. They may even be more effective in patients than they are with physicians, given the vulnerability of patients and their more limited resources. The new cystic fibrosis drug Trikafta and its precursor drugs are a flashpoint for much of the anger directed to the PMPRB. From the evidence we've seen, these new CF drugs are that rare product, a breakthrough treatment. We want Canadian CF patients to have them, but simply being an effective drug doesn't justify price gouging. Drugs are supposed to work. Otis Webb Brawley, the former chief medical officer of the American Cancer Society, argues that, quote, patient groups get money from the drug and device companies because they make claims so outrageous that even special interests dare not make them. Some of the claims that cystic fibrosis and rare disease patients are making about the PMPRB fit that description. And I refer to tweets like, at Doug PMPRB, you are promoting the death and suffering of Canadian citizens, and the blood is on your hands. I refer to the emotionally charged images in the ad series, Stop Changes to the PMPRB Regulations, which was sponsored by 13 patient organizations called Protect Our Access. The PMPRB didn't block Vertex from bringing Trikafta to companies sooner. That was the company's decision. Notably, patient advocacy groups in other countries have challenged Vertex directly, as they should, and not their cash-strapped public health programs. Patient charities supported by the pharmaceutical companies often develop financial assistance programs to help patients pay for the excessively high-priced drugs. This doesn't solve the problem of patient access to high-cost drugs. It serves to maintain an unsustainable drug pricing system that is enormously profitable to pharmaceutical companies. It keeps drug prices high. In conclusion, partnerships between pharmaceutical companies and patient organizations contribute in myriad ways to inflate drug prices and to skew patients' advocacy in favor of the industry. Canada needs a national, publicly funded drug plan and policies to support it. Breast Cancer Action Quebec recommends that the new PMPRB guidelines go into effect July 1st, 2021. And I thank you. Jennifer and I are happy to answer any questions.
Thank you, Ms. Batt. We go now to Cystic Fibrosis Canada. Ms. Grover, please go ahead, 6 minutes.
Hello, and thank you for inviting us here today. I am the CEO of Cystic Fibrosis Canada. Cystic fibrosis is a fatal disease affecting over 4,300 Canadians who die far too young. We are, however, at a time of extraordinary change for this disease, as there are now drugs that can help 90% of our community live much longer, healthier lives. The next best thing to a cure is on our doorstep. When we first put forward our submission to this committee, we wanted to discuss the opportunities and the challenges we saw with respect to the implementation of the PMPRB changes. We wanted to stress that we agreed with the goal of lowering drug prices and the changes to the comparator countries, but we had concerns about the additional pharmacoeconomic elements. While we stand behind that thinking, today I need to share serious concerns we have about the approach and the conduct of the PMPRB. Drug policy is important and it can have a life or death impact. With a drug policy change of this magnitude, it was our expectation that the PMPRB would ensure there was meaningful consultation with those most affected. However, in our experience and in the experience of many other patient groups, this was not the case. Our submissions were sent into what felt like a vortex and ultimately were never reflected in the minimal revisions made by the PMPRB, nor were explanations on their chosen direction given. Last week, we learned of activity at the PMPRB which solidified our concerns about the value placed on patients. We learned through an ATIP request that the PMPRB had developed a communication strategy to discredit 4 groups. 3 of these groups were patient groups, including the cystic fibrosis community. To quote the PMPRB strategy, quote, "Opponents of the reforms have been more vocal about the potential negative impacts of their implementation and are spreading disinformation through organized public relations campaigns," end quote. Further, it's noted, quote, "The CF community have aggressive public relations strategies that are aligned with the messaging promoted by the industry," end quote. I want to make a specific point here. The word disinformation is highly inflammatory and was a deliberate vocabulary choice by PMPRB officials. We now understand that if you dare to disagree with the PMPRB, they won't simply refute your point of view, they will villainize your efforts. As the CEO of a nationwide organization dedicated to serving people with a fatal disease, who now have an opportunity to access life-changing medications, I cannot fully convey the dismay and concern I have that a federal agency deems this community to be an opponent and a threat to be discredited. To specifically target the credibility of this community, children and young adults who are fighting for their lives is beyond what I could comprehend as reasonable or appropriate for a federal agency. These families felt these changes stood in the way of them accessing new life-saving medications, so they spoke up. Members of Parliament who disagreed with the PMPRB's directions should also be concerned, as they too were characterized as spreaders of disinformation. This characterization should be very concerning to the members of this committee, as the role of elected representatives is to assess policy direction. My final remark is with respect to another ATIP request that showed calculations conducted by the PMPRB on 2 cystic fibrosis drugs if the guidelines were implemented. The calculations indicated that the manufacturer would be required to reduce their price by 99%. We found this to be of keen interest. Why? Because time and time again, the PMPRB told us that our concerns were not valid and the impact on industry was overblown. Well, whatever you think about the pharmaceutical industry, we believe that most of us can agree that there isn't a company in any sector that would raise its hand to come to a country that requires a 99% reduction in price. These examples illustrate an agency that we have grave concerns about. As I noted earlier, we support the government's goal of lower drug prices. However, we believe that this must be accomplished in a transparent, credible, and consultative manner where all parties are listened to and, frankly, those with most at stake, Canadian patients, respected. This has not been the case with the PMPRB. It is incumbent on the Standing Committee on Health to stay these guideline changes and to call on the Auditor General and the Integrity Commissioner to review the activities of the PMPRB. Thank you.
Thank you, Ms. Grover. We'll start our questions now. We will start with Mr. Kamick, please. Go ahead, sir, 6 minutes.
Thank you, Mr. Chair. I'd like to start with Cystic Fibrosis Canada, because you mentioned obviously some public information that I released once I had obtained them. My experience has been that patient advocacy groups like yours and others are usually parents, moms, dads, and teenagers who have a particular condition and who are very active in it because it's very personal to them. I have 3 kids with a rare disease. I have a daughter who passed away just a few years ago from a different rare disease, so it's very personal to me as well. Can you tell me, like, the people involved as advocates, are they paid lobbyists, or are they moms and dads and parents?
Thanks for your question. So people living with cystic fibrosis who advocate are just free agents who are living, they're parents of kids who are sick. They are adults now who are living longer lives, which is a wonderful moment. I just want to stress that the drug available for these people is for 90% of a fatal disease, and it adds 10 years of life. They are fighting hard. They saw barriers, so they spoke up. And these are just an amazing community, and I'm so pleased to lead cystic fibrosis on their behalf.
So Kelly, can you tell me, when the documents came out, and obviously the communication plan accuses you, your group, and other patient advocacy groups, and actually parliamentarians like myself, of engaging in disinformation. So essentially we are deceitful and we're lying, which is what the PRB accused us of. How does that make your organization and the people you represent feel?
I was talking to my team about this today. I feel sad. I feel really, really let down. We are a 60-year organization who was built by parents and is now our board chair as a parent of somebody living with cystic fibrosis. And we are so committed to changing the course of this disease and doing the work that's needed. There is a rhetoric out there that we don't speak about Vertex, or the manufacturer, we don't do this or don't do that. I'm here today for the moms and dads living with cystic fibrosis, and we have such an opportunity to change the course of this disease. And I'm a bit saddened that it's come to this. It's really about slagging each other, and I think we should all come together and figure this out and ensure that people who have a game-changing drug are able to get access in Canada. I think we all could champion that. So it makes me very sad and just frustrated, frankly. And I know that's how the parents felt. They felt very slagged, if I can use that word, and really, really disrespected, and they're frustrated.
So after, so in these internal documents where they accused parliamentarians like myself of lying, you responded, in May 24th, you sent a letter to the president of the Treasury Board and to the Integrity Commissioner. You specifically cited major concerns that the PMPRB had violated the Policy on Communications and Federal Identity, Section 4.1, and also a Cabinet Directive, 6.10.2, on the management of communications supposed to be done objectively and in nonpartisan fashion. Do you have any concerns about the neutrality and professionalism of the PMPRB executive?
So that letter didn't come from us. It came from a sister organization called the CF Treatment Society. I'm not going to speak to the leadership of the PMPRB. I believe that people, I think the staff probably work hard there and try to do the best they can. What I do think is that they didn't have a sound consultation process. One that I would expect would have been more of a to and fro and not didactic in one way. And I think that patients and people living with disease have a lot to offer. And I think that you could have had a more meaningful, there's many things, and I can submit it later, I could say about the consultation. I think you could have a more meaningful discussion on the changes. I think that they're, and we've said this as Cystic Fibrosis Canada, we do agree with the changes. We do agree with lower drug prices, and we agree with some of the guideline changes. And then we think maybe you should wait and see and try some out and see how it goes and learn from the experience. So I think it just becomes very didactic and black and white. And so, you know, I can't speak to the leadership, so I'm answering a bit in a roundabout way.
That's okay. On the public consultation, because that was going to be my next question. I have emails, obviously, that I've made public in an effort to, share with the public what I have found out. I would like to know, do you think these public consultations were done impartially now that we know the emails that they were sharing amongst each other as follow-up to these meetings, and whether the PMPRB guidelines should go ahead July 1st or whether they should be directed to redo the public consultation in a fair and open manner?
So we think the consultation should be redone in a fair manner. So that we've been public about that. We don't think that was done.
Mr. Chair, how much more time do I have?
You have 40 seconds.
40 seconds. Okay, so this will be my last one here. The other patient organizations that you've spoken to in regards to PMPRB, on a go-forward basis, do you feel like the PMPRB will give your organization a fair shake in light of the fact they have this $56,000 communications project they're working on to discredit you and other patient advocacy groups?
I think the PMPRB is not set up to work with patient organizations, and they feel threatened by people when they speak up. And when parents felt that there could be a barrier to their drug, they spoke up. And I think that you have to be prepared for that when you're forward facing and you're changing drug policy that is life and death for people. And they were not prepared for that, and they felt it very offensive. And I'm not condoning disparaging remarks, but when people are feeling a sense of panic, they are going to talk to who they think is in the way of their of access to their drug, and that's what they did.
Thank you, Mr. Kamick. We'll go now to Ms. Sadhu. Ms. Sadhu, please go ahead. 6 minutes.
Thank you, Mr. Chair. I would like to thank all our witnesses for appearing today. I will start my questions to Dr. Morgan. Dr. Morgan, I know you have written about different models for pricing drugs and how they can better serve patients. Can you speak to how models based on fixed costs or patients' ability to pay might apply in Canada? Is there room for such a system in the PMPRB's proposed model?
So I'm not particularly clear on what you mean by models based on fixed costs. However, I think it's important, and actually some of the other witnesses have mentioned, I think everybody is opposed to excessive pricing of medicines, pricing that can't be defended on the basis of value for money in a healthcare system. Because pouring, for instance, millions of dollars into treatment for a particular patient or a few patients is money that's not being used to meet other healthcare needs and also other needs of patients with the same disease. We know that we don't want to be providing excessive returns to investment in pharmaceuticals if there are other investments and innovations in healthcare that might deliver as much or more return to the economy, or to the health system. So there's a desire to stop excessive pricing, and there's also a desire to make sure that pricing reflects something approximating the value to health systems. And we've heard this even today, that the best strategies are to set upper limits on what prices could reasonably be in a system that tries to reflect return on investment to R&D and value for money in health systems. And then frankly, you need to let the buyers and sellers of medicines negotiate prices. And this is something that Canada lacks a strong capacity for, because we have a fragmented and uncoordinated system of private insurance in this country that simply lacks both the technical skills and moral authority to make value for money decisions in a healthcare system otherwise publicly financed. So Canada needs public agencies to do negotiations of the final prices, those confidential net of rebate prices, that make sense in terms of value for money. Increasingly, that means also engaging in risk-sharing agreements with manufacturers that address the real and significant uncertainty about whether products work as well in the real world as they are promised based on often very small clinical trials. Canada has the opportunity to build that capacity in the Canadian Drug Agency that is currently in the process of being established at the federal level, and in partnership with the provinces and other national agencies and provincial agencies concerning health technology and price negotiation.
Thank you. And affordability is an important concern for everyone. An issue that regularly comes up when I speak to my residents, Bramptonians, is how increasing drug costs and insurance premiums impact their budget. As we all know, the government is working to move forward in establishing the fundamental elements of Canada's pharmacare. To what degree do you believe lower drug prices result in overall saving for Canadians on their insurance premium if the new guidelines are introduced?
So the new PMPRB guidelines will affect prices to some degree in Canada, but it is important to recognize that if you bring down the list prices of medicines in Canada, you may not have as dramatic an effect on the final net of rebate prices. So for example, let's just pretend a price of a medicine is $100 as a list price, and the manufacturers and provincial drug plans have negotiated that $70 was actually value for money, which is about right in terms of the average rebate that they negotiate on behalf of public health systems in Canada. Now imagine the PMPRB regulations bring the list price down to $90, not $100. The final price to the provinces is going to continue to be $70. Now, the private insurance companies are going to save the $10 of reduction in list prices, but the net savings to Canadians in terms of the public programs, that is ultimately determined by price negotiation power. Now, the exception to that rule is on these very expensive drugs for drugs that treat very serious conditions. We've heard some examples with CF treatments. There are other examples across the spectrum in terms of needs of patients, where because there are just one or two medicines that truly effectively treat a given condition, the prices can be so high that there is no such thing as people paying cash or buying the medicine at the pharmacy, and entirely pricing is arrived upon by negotiation between public plans and the buyers. And it's in those negotiations where the PMPRB regulation has significant potential to prevent the systems that we have for our public health care from being abused, in the sense of being held captive against really excessive price asks by manufacturers. And I'll just add, I know there's a yellow flag there. This is one of the reasons why countries around the world are paying close attention to what's happening here in Canada with these regulations. I think there are countries around the world. I say this as a person who for the last 15 years has hosted an annual meeting of people responsible for pricing, regulation, and health technology assessment in about a dozen high-income countries. The members of that group, known as the Vancouver Group, because I'm their host, have often reflected on these regulatory reforms that are underway in Canada because they see them as potentially valuable even in their systems.
Thank you, Ms. Sadu. Nous allons maintenant à Monsieur Thériault.
We go now to Mr. Thériault. Mr. Thériault, go ahead, please. 6 minutes. Thank you, Mr. Chair. When an organization is responsible for putting forward a reform and holding consultations, it has and in a press release, it discredits stakeholders in the consultation. I think that's in bad faith, and I think it can end poorly. Having read all of the briefs, there are overlapping points to highlight, and I think that is what we should focus on today. For those who are concerned about conflict of interest, there's an organization called Research Canada that represents university centers, health sciences, universities and colleges, research associations, charities, excellence networks, biopharma, so a number of people and institutions who have the same fears as you, Ms. Pirot. On page 2 of their brief, for people who are going to ask where I found this, they're saying that the federal government is navigating without any visibility. It's doing things blindly in terms of reforming the PMPRB. And the conclusion is that the lack of inclusive consultations regarding the guidelines, but also for the reform, could be costly for our economy, our healthcare system, and our most vulnerable patients. What do you think? You're directing the question to me, I imagine, Mr. Thériault, because you said my name? Listen, it's clear to us the current reform seems to have been designed in a silo. Our industry, our ecosystem, works horizontally. It's a chain of innovation that starts with research in universities, and we hope it gets to the marketing of new medications, new drugs. And there are many players, including biotechs like us, clinical and preclinical research, and we work in an integrated fashion. If you hit one of the links of that chain, and if it's weakened, the whole chain is weakened. In Ottawa, unfortunately, changes are being designed to a regulation thinking in a silo, only looking at the price of medications and drugs. But the ecosystem is much broader. It's about research, innovation, economic development, clinical research, integrating innovation for patients. It's much broader. And that broader consultation wasn't done in Ottawa. In Quebec, we're working with a Quebec strategy for health sciences under the responsibility of 2 ministers, the Minister of Health and the Minister of the Economy and Innovation. And that already shows that there's an integration of our ecosystem, an understanding of that ecosystem, that it is working horizontally and not in silos. So that's very important. We're certainly disappointed to see that all of the partners in this reform weren't adequately consulted, whether it's us, biotechs, or patient groups, people doing clinical research, and even more importantly, the provinces. The provinces manage healthcare, and currently the government of Quebec is officially opposed to these changes to the PMPRB. The government of Ontario has reservations, and so does the government of Alberta. We can't put in place a strategy like this one without including the people who will be implementing it, like the provinces, so we need to redo this. In fact, there's a Quebec strategy for life sciences, but there isn't one at the Canadian level, and there's a lack of vision, a lack of strategic vision. And so the drug price is just a cost rather than
something part of a broader picture. We are told that there won't be any impact on the price of medication and that they're talking about disinformation. I'll give you my opinion, and I will ask Mr. Levesque to intervene as well. As CEO of a company, access to market is an essential element in the innovation chain. When access is restricted in Canada, the whole ecosystem will unfortunately suffer. We're already seeing, I have members who've told me that there's less clinical research being done, fewer innovative medications that have been launched. They've been launched elsewhere, and those drugs haven't been brought here. I'm not talking about being approved here, but the companies aren't even bringing the drugs to Canada, so patients won't be able to benefit from them. So there will be impacts. There will be negative impacts in our opinion, and that whole chain hasn't been taken into account. Paul, maybe as CEO of a company that is working on drugs now, maybe you can respond. Yes, thank you. Earlier, I tried to say that if there's a price that's half of the American price, the product won't be brought here. I can tell you that right away. I face these situations. There's no one else but me here who makes those decisions. And if you look at a $100,000 price in the United States, that nobody pays, by the way, it can be negotiated. That price can be negotiated. But having the price be 50% is unbearable. We can't work with that. Listen, I can just tell you that the Canadian pharmaceutical industry is dynamic. It was dynamic 20 years ago, but it's been marginalized through policies like this one. And this policy will mean there will be less and less innovation in Canada. Somebody said earlier, at a time when there is very high value innovation happening, there will be therapies for things that couldn't be addressed before in cancer and for all sorts of diseases. This reform is coming at a very bad time. We're at the end of a pandemic where we saw the value industry can create.
At this time is to nurture the pharmaceutical industry so that you have something homegrown that can help you out. Today you need a vaccine, tomorrow you're going to need an antibiotic. Who's going to do it? The government? You need a strong pharma industry. Does that mean that you have to pay super high price? The answer is no. Get a reorg, get a reform. Dr. Morgan said that. We can be more efficient in the way we negotiate at the provincial level. But this is the wrong reform at the wrong time. We are actually trying to impact the wrong variable in the whole equation. Monsieur Thériault, j'espère avoir répondu.
Mr. Thériault, I hope I've answered your question.
Sur mute, Monsieur le Président, j'aurais pu.
Mr. Chair, you're on mute. I could have made another question.
I'm wise to those things. However, thank you. I apologize for being on mute. Thank you, Mr. Levesque. Merci, Monsieur Thériault and Monsieur Levesque. We'll go now to Mr. Davies, 6 minutes.
Thank you. To Dr. Morgan first. Dr. Morgan, in 1987, Bill C-22 amended the Patent Act to expand the patent rights of patentees of medicines. And those amendments included, among other things, an extension of the patent term from 17 years from the date of the issuing of the patent to 20 years from the date of filing of a patent application. To ensure that the prices of patented medicines are not excessive during the expanded period of market exclusivity, that bill also amended the Act to create the PMPRB. Quick question to you. Would you say that pharmaceutical prices in Canada are excessive as a general statement?
Yes, but in comparison to international comparators, most notably those in Europe and Australasia, there's no question we pay higher prices. In comparison to what in private insurance companies in the United States pay and what national agencies like the Veterans Administration Health System pay in the United States, unquestionably our prices are excessive in Canada.
Thank you. I mean, I see figures putting Canada either third or fourth in the world, depending on the source, in terms of the prices Canadians pay for pharmaceuticals. Is that accurate?
Yeah, approximately. And in fact, that's an account of list prices. And if you looked at comparator countries, high-income countries with universal healthcare systems, Canada is probably one of the highest price-paying markets for pharmaceuticals, even after you account for the negotiations that our provinces undertake. And that's because a significant proportion of our medicines are purchased by private insurers or by uninsured Canadians, both of which have little or no negotiating power with manufacturers.
Thank you. So I understand the order of priority is the United States pays the highest. I think Switzerland is second highest. I think Germany or Canada is third highest. My question to you is, of the countries that pay lower costs, I guess there's 100, 210 countries in the world, the Belgiums, the Frances, the New Zealands, etc. Do they have less access to medicine than Canada does?
Yeah, that's a great question. And people throw out these statistics about, and these stories, frankly, about drugs that don't come to market in Canada. The fact is that drugs go to market in a few places in the world in very large numbers. And then in other markets around the world, they go to market basically on the basis of whether or not the drug is truly, a breakthrough that will earn market share. In places like Germany and the United States, the legislation of those countries is set up to give manufacturers every incentive to bring anything to market, regardless of how clinically promising it is. But ones that are clinically promising end up in markets around the world. The literature on this, which I recently did a systematic review on, is quite poor internationally because most of it is funded by pharmaceutical manufacturers. And as a consequence, most of that literature has what we call a commercial bias, a bias that says that any drug in any market at any price is a good thing. The reality is that it's effective drugs that countries want, and effective drugs get to every market of the world.
So not to put too far, I really want a direct answers if I could, Dr. Morgan, because there seems to be a thesis developing that if we go through these PMPRB reforms and it reduces the price of drugs, Canadians won't get access to those drugs. So I'm asking, in a real world environment where there are many countries that already pay less per drugs than Canada does, are they getting worse access to drugs than Canada is?
No, and one only needs to look at, for instance, the United Kingdom, a country that pays less than us, gets more medicines on its market, and actually has higher research and development in the pharmaceutical sector. So there you go.
Thank you. Ms. Batt, to you, will these PMPRB reforms discourage clinical trials in Canada, in your view?
Ms. Batt, you're muted, please.
In my opinion, I haven't seen evidence that it will, but obviously that's up to the companies where they do their clinical trials. And, I'm not sure how important the PMPRB guidelines are to those decisions. But I have to say, I don't have,
Okay, I'll move to the next question. In your view, will PMPRB reforms discourage new drugs from coming to Canada?
No, as Dr. Morgan said, I don't see the evidence that the really good, important drugs won't come here. If that there's going to be the demand, and I don't see how the provinces are going to want to not welcome drugs that are actually going to make a difference. And Canada, it's certainly a smaller market than the United States, but it's not a trivial market. We're spending a lot of money on drugs. I don't know why the companies would walk away from our market just because their prices are reduced a bit.
Well, one theory is that, and I think recently there was media reports that the pharmaceutical industry offered the Canadian government $1 billion in order to delay bringing PMPRB reforms in. And according to an industry estimate, they say the regulations would reduce drug companies' revenue by about $19.8 billion over 10 years. Do you think that the opposition of the pharmaceutical industry to these reforms is based more on their own interest in their own profits, or in their concern that Canadian patients won't get access to drugs?
I think they are concerned about their own profits. And I think, certainly the United States is very concerned about high drug prices too. And they're looking to Canada. And if Canada gets an effective reform in place, I think there's certainly some concern on the part of the companies that that the United States could follow suit. And I think that kind of the dynamic between the two countries is very interesting and is very likely a factor in the drug companies' opposition to these new guidelines.
Thanks. A quick question, Dr. Morgan. Dr. Morgan, what percentage of research is created from publicly funded research, like in universities, that goes into new molecules? If you can give us a rough estimate.
So I don't have the number off the top of my head. I know Chris McCabe will be speaking later with this committee. He might have that number. It's a significant percentage, particularly if you include tax expenditure subsidies, which we provide for the private investment, in addition to government grants and nonprofit organizations sponsoring research itself.
Is there a ballpark?
I don't want to give you a number that without having the statistics in front of me.
Thank you, Mr. Davies. So that ends our first round of questions. We'll start our second round at this point. We'll ask Mr. D'Entremont to proceed. 5 minutes, please.
Thank you very much, Mr. Chair, and I want to thank the witnesses for being here today. We've taken, I would say at this point, hundreds of memoirs from organizations that have presented to us, and I think they're as diverse as the views that we see here today. And quite honestly, this is meeting 2 of a 3-meeting process, and we're getting close to, I believe, the end of our process, where we need to have an idea of what we're going to recommend, and yet we have PNPRB changes are going in place, in just a few weeks. So, we're trying hard to synthesize a lot of the things that we're seeing in before us. But it was 6 months ago that we had our last meeting. We invited the PNPRB to be at this meeting to sort of bounce some of these thoughts and thoughts and consultations off of. Unfortunately, they didn't want to be here today, which I find that a bit awkward as we're trying to find ways to, in my mind, help them come up with the best piece of rules and regulations in order to do that. So we talked a lot about pricing today, but we had the issue of the other side of the equation. I think there's 2, we talk about the patient side. So Kelly, Grover, thank you so much for being here on behalf of CF patients. I get a lot of folks from the patient groups talking to us. And I know Tom probably will ask a few more questions on this if he gets the opportunity, but, have you gotten an apology from PNPRB on their true, attack on patient groups? And I find it difficult that we're attacking patient groups right now.
No, thanks for your question. And I've met with many of you. We've met with many of you, and you've met with your constituents, and we thank you for that. We didn't ask them, CF Canada, we didn't ask for an apology, but there was another letter this week that was written to another patient group that wrote, that was called out, and there was a letter written, I was copied on it, from the board chair of the PNPRB. And I think that's when I said before, and I'm sorry to keep talking about my feelings, but I felt just really disappointed and sad with the letter, because the tenor of the letter, if I had had a comms plan and I did something wrong or whatever, I might have started with, I'm sorry you felt that way. Here's where we're coming from. But that was not of it. The tenor of the letter was almost like they doubled down. They're very offended by the patient groups, and the Ms. Batts or Dr. Batts spoke to some of the language online. They're very offended by that, and there's no consideration of where patients are coming from. There's no understanding of that or trying to empathize with that. And on top of that, something that I found curious was they stated in their note that they are the experts on this. And that's what they advise government on. And I found that curious to use those words, because I thought this was a consultation process where we all bring in, Dr. Morgan suggested things, we all are bringing our voices to the PNPRB to make these the best guidelines. And I might be a bit naive on that, and I'm not trying to play that card with you right now, but that if that was the point, you were just information gathering from all of us and it wasn't a consultation process, then call it that. But that wasn't what it was called. And if you look at their consultation principles, It's about meaningful discussion and debate, and that didn't happen. So we haven't had I don't expect there to be an apology to us, to be honest. I'm not going to waste my time on that. We were invited here. We've written our letter, and that's that.
All right. Thanks, Kelly. The other side of it, so we got patients on one side, which from a health system standpoint, patients should be number one on that. And then, the time I spent there, it was about patient service and trying to find better ways that people could get their treatments and drugs and whatever they possibly needed from our healthcare system. But we also have the other side. I see Minister Champagne actually out there trying to bridge a few gaps right now, because of the way the PNPRB is coming down, that he's reaching out to research and development and drug companies. So peut-être c'est une question pour Madame Perrault.
Perhaps it's a question for Ms. Perrault. Where do the investments come from for research which is done in pharmaceuticals? Listen, investments come from a number of sectors. Thank you for your question, Mr. D'Entremont. It's clear that pharmaceutical companies, the members of biotech are not big companies. They're preclinical and clinical trial companies, among others. They're part of the ecosystem. That ecosystem is very different from what it was 10, 15, 20 years ago. It's really changed. It's much more horizontal now. Big pharma is involved in academic research now, in biotech, in clinical trials. Venture capital as well come from a number of countries. They're international. So it's not true that we work in silos. We work much more horizontally. So research is funded by public money, yes. Basic research, fundamental research has a lot of government involvement, but there's a whole ecosystem around that. And I would also add, Mr. D'Entremont, that if public money allows for research, and we do very high-quality research in Canada, I would want Canadians to benefit from that research. Because at the end of the day, the drug that would have been worked on throughout the world, there would be research done here, there, and everywhere, but Canadians will have contributed to it. Vaccines for the current pandemic, Canadians contributed to them through mRNA and trials. A lot was done in Montreal. It would be unfortunate for Canadians not to be able to benefit from this. Maybe later, some countries receive drugs very quickly. Other countries will receive them as well, Canada too. But when? Will we be in the second or third category? I want Canadians and Quebecers to benefit as quickly as possible. So this reform, which looks only at the price of drugs, should take into account the whole ecosystem and how that ecosystem can benefit Canadians in the area of research, innovation, clinical research, and drugs, so that patients can benefit. So it's the whole picture. Thank you.
Désolé.
Merci, Monsieur D'Entremont.
Thank you, Mr. D'Entremont.
We'll go now to Mr. Van Bynen. Mr. Van Bynen, please go ahead.
Thank you, Mr. Chair, and thank you to this panel for joining us today. I think that all of us can agree that this is a very important discussion, and I appreciate everyone taking the time to join us. My questions will be directed towards Dr. Morgan. Canadians have access to some of the best doctors, nurses, hospitals, and treatments in the world, and all through our publicly funded healthcare systems, including the incredible team at South Lake Regional Health Centre, where I'd had the pleasure to volunteer as a board member for many years to gain some insight into the healthcare sector. We've learned that some Canadians, particularly those with rare diseases, have difficulty affording the medications that they need. And Budget 2021 reaffirmed that the government will proceed with its announced plan to provide ongoing funding of $550 million for the program for high-cost drugs for rare diseases. Now, how do you think this investment will help Canadians currently living with rare diseases now and in the future?
Thanks. It's a great question. I think there's a few things that are underway. The federal government is consulting to try to develop something of an actual strategy around rare diseases, because Canada has lacked that to date. And I think that that's very promising, because there's funding for the medicines when patients need them, but there's also the various mechanisms that need to be put in place for the assessment of medicines as they come to market, and to support both manufacturers and patients in navigating often complex and often uncertain information about whether the medicines are going to work or not. The $500 million that's dedicated towards helping provinces pay for expensive drugs for rare diseases, I think, is an important step in the process of developing a truly comprehensive national pharmacare program. And for patients with rare diseases, I think it's a clear signal that they will not be left behind by a pharmacare program that is designed to cover medicines that, all of the medicines that Canadians need. Because I know there was a lot of fear at the outset of discussions around national pharmacare that patients with rare diseases would become, the second or third in line after the patients with more common conditions like diabetes, asthma, and other such things.
Yeah, I'm looking at an article which is entitled "Pricing the Pharmaceuticals is Becoming a Major Challenge for Healthcare Systems." And in that article, it is said that the pharmaceutical sector can potentially abuse market power because of the inelasticity of demand for necessary medicines. Can you expand on that, please?
Yeah, absolutely. I mean, the idea of having a patent be a mechanism for incentivizing research and development is typically comes from markets where the price that a consumer is willing to pay is based on the idea that the consumer can always walk away from a transaction on a voluntary basis and not be harmed unduly by doing so. Unfortunately, in the context of necessary medicines, particularly for serious diseases, patients can't walk away. And as a consequence, patients and their families would pay virtually anything for effective life-saving treatments. And as a consequence, patients and their families and their organizations would try to convince governments to pay anything for effective life-saving treatments. This gives patent holders in the pharmaceutical market very unique market power that the patent system really wasn't designed to provide. And that's why safeguards like PMPRB regulations are a useful tool to make sure that there's incentive for innovation, but not an opportunity to abuse the market power of the patent.
Thank you. Now, one of the conversations that we're hearing lately around patents in relation to the COVID-19 vaccine, I'm curious to hear your thoughts about the patent process in relation to pharmaceutical drugs. Can you identify any areas where Canada could improve or further encourage pharmaceutical companies to develop their drugs in Canada?
So, if you want an innovation strategy on R&D in the pharmaceutical sector, you've got to improve the productivity of the R&D itself. Manufacturers locate their research and development investments based on science. If you want good scientific research conducted in Canada, invest in Canadian science, invest in data platforms, invest in clinical trial networks, that kind of thing. Paying higher prices isn't necessary to attract R&D, and countries like the United Kingdom prove that. You can actually have effectively managed drug budgets and significant pharmaceutical sector investment. So focus on science, put the investments into the scientific enterprise in Canada, and that's where you're going to get your best return on innovation policy.
Thank you. That's a great segue to my next question, and I'd like to direct that question to either Ms. Perreault or Mr. Levesque from Bio-Quebec. I know that supporting Canada's biotechnology and life sciences industry is a priority for this government that goes beyond responding to COVID-19. Budget 2021 proposes to invest $2.2 billion towards growing and strengthening our domestic life sciences sector, including $92 million for Admare Bioinnovations, which is based in Montreal to support company creation, scale up, and training activities in the life sciences sector. What impact do you think these investments will have on Canada and Quebec's life science and biotechnology industries?
Well, I can answer. Well, do you want to go ahead, Paul, on this one?
No, go ahead and I'll compliment.
Okay. Thank you, Mr. Bynon, for your question.
Let's make it a quick response. We're way over, so thank you.
Oh, okay. Well, actually, I'm applauding the investment that the Canadian government has made recently in the sector. But my point today, Mr. Bynon, is that the ecosystem is much larger than just drug prices. It's about much more than that. And we don't have a Canadian life sciences strategy right now. It does not exist. And I think we should have one, and we should take that opportunity that the pandemic is giving us and the rebound that the economy should take to actually think about putting in place a Canadian life sciences strategy that will take into consideration drug prices, but also much more than just that.
Thank you, Mr. Chair.
Thank you, Mr. Van Bynen. We're going now to Mr. Kamek. Mr. Kamek, please go ahead, 5 minutes.
Thank you, Mr. Chair. I wanted to ask first maybe a question to Mr. Levesque. I'm reading just here from an email from PMPRB executives from December 5th after a meeting they had with industry groups. In it, they say that industry, well, one of them says, industry has been sucking Canada for decades. But from all the discussions I've had here, you don't seem to do that. You provide jobs, you're an R&D, you do work. What do you think of that coming from an executive at the PMPRB responsible for stakeholder relations?
Well, I mean, you know, the life science sector is important. And if we haven't actually draw that as a learning as part of the pandemic, I don't know what is important to take. I don't represent a multinational. I'm a homegrown you know, pharmaceutical company, and we don't have a lot of those. You know, the reason why, you know, Dr. Grover was just saying that in UK, they get some benefits from the industry despite having low price. They have a homegrown. AstraZeneca is from there. It's a multinational that is homegrown in UK. What is the equivalent in Canada? There are none. So that's the point. We're one of them. And Mr. Biden had a very good example in a moment ago in his questions where he says, well, we are providing a lot of money in that sector. And that is true. We're being helped in terms of income tax credit. We're being helped in all kinds of areas, but we cannot sell. Or we are having a hard time to get reimbursed by the governments. So it's just like if, you know, you support the industry in manufacturing 2x4s, but you don't want the 2x4s to be sold in your territory. That's the way I feel as a Quebec homegrown pharmaceutical company. So what you need is, yes, continue to actually nurture and put money where it can have an impact. But quite frankly, I don't need that much money. I would like to have access to the Canadian market, just like I have access to the US market, just like I have access to the EU market. What I'm telling you is that I'm very proud of being here. And I actually, the model that we have here in Quebec is that a lot of the research comes from the local university. We've made deals with them. We canalize, in a way, their, you know,
Thank
Canadian.
you, Mr. Levesque. Sorry to interrupt you, but I want to ask one more question to Cystic Fibrosis Canada. I have the letter that Kelly, you sent May 27th. So the PMPRB refused to show up today to testify. We can all make assumptions on why they refused to show up. But in it, you call for a stopping of the changes the PMPRB is trying to introduce through guidelines, but also to conduct a full investigation of the agency and its work. And you said you sent this to the Prime Minister. Have you heard back from the Prime Minister or anyone in the government? And what type of investigation did you have in mind?
So we've not heard back from anyone. And I just thinking and listening to everyone, I sort of wanted to stress something of, we were called out as a patient organization for spreading disinformation and for being an opponent, yet we agreed with some of the changes made in the PMPRB. So I find this very curious. So I wanted to make that clear. We also were asked to be part of a consultation, which we took our time. We're very busy. We're trying to actually get a drug funded in Canada, which is no small feat for a rare disease. So I wanted to make that clear. In terms of the investigation, it's outlined in the CF Treatment Society letter. We'd be looking for the guidelines to be stayed while we look at the conduct of the PMPRB, how they are consulting with patient groups, and then how they've maligned us or intended to in this. They maligned in the document. Whether the document was put into action, I couldn't say. But they, as I said earlier, the board chair doubled down on this, and so did Mr. Clark, who was asked about it in a media report. So there's nothing wrong with combating to doing a communications plan. Calling people liars and spreading of fake news who are trying to do the best they can as a charity, and the community, I find it really concerning. And I think you should be concerned, and I think the Prime Minister should be concerned, and I think the Health Minister should be concerned.
Thank you for that. Maybe just one last question. Obviously, you're talking to other patient advocacy groups in the lead up to the implementation of these regulations July 1st. Should that come about, should the government not delay it further or maybe stay them like you've asked them to do to conduct an investigation of the PMPRB, what will you do, I guess, in the 6 months afterwards in order to advocate on behalf of the families who are affected by cystic fibrosis? And do you trust the PMPRB to conduct the implementation?
So I'm going to answer the last and come back. We don't trust the PMPRB to implement the implementation, and they're doing consultations on the evaluation right now, and none of us knew about it because it was promoted on Twitter, and we're not on Twitter all the time. So that was a bit of a problem. In terms of what are we going to do, honestly, we only have so much time and so much energy, and so does this community. We need to get Trikafta into the hands of people who live with this disease, and that is not going to be through the PMPRB now. So we have to turn our attention over to our provincial partners and hopefully see this drug funded. We are concerned about the future of cystic fibrosis drugs at this time, but as I said, we're going to keep our eye on it. And also, Dr. Morgan spoke about the rare disease framework. So we're interested, obviously, in that as well. So there's only so much time and energy, and the priority is getting this drug here now.
Thank you, Mr. Kmiec. We go now to Dr. Pawlowski. Please go ahead, Doctor. 5 minutes.
Well, first, let me start off by saying nobody should ever question the integrity of parents of sick children in doing what they're doing. And certainly, I don't think anybody's lying. I think, however, there might be some disagreement as to how to best help Canadians, including Canadians with cystic fibrosis. And in passing, I know one of my kids' best friends has cystic fibrosis and certainly would like access to Trikafta. Now, a question for Ms. Grover, and hopefully could be fairly brief. Vertex for a long time was refusing to ask Health Canada for approval for Trikafta. I know Cystic Fibrosis Canada has been advocating for, lobbying for these changes to the PMPRB to be withdrawn. Has Vertex at any time asked Cystic Fibrosis Canada to lobby the government on this issue?
No.
Have they told Cystic Fibrosis Canada that the reason that they aren't or they weren't asking for approval from Health Canada was because of the proposed changes to PMPRB, and unless those changes were withdrawn, they wouldn't submit the drug for approval?
They didn't tell us that, but they was told publicly.
Okay, thank you. So I would like now to address my questions to Professor Morgan. And if there's time, I will give Ms. Grover an opportunity to respond to this too. Professor Morgan, do you think, in your opinion, do you think drug companies are using patient advocacy groups to basically doing the lobbying for them in order to further their own business interests, and by refusing to put an application before Health Canada for their drug Trikafta, are they not holding sick Canadians with cystic fibrosis hostage to their demands? Now, because I want to get this part of the question in as well, what are pharmaceutical companies really afraid of? I think it might be because these changes, and I've heard what they're really afraid of is because these changes to the PMPRB would basically allow other jurisdictions to figure out what the actual price our country was paying for drugs and purchasers in our country. This is a jealously guarded secret. As you've said previously, they don't want countries to know what other countries in other jurisdictions, other buyers are paying for their drugs. With these changes to the PMPRB, it would allow HTA and pharmacoeconomics in the PMPRB to set a maximum price based on HTA on a maximum quality saved, and so when PMPRB was looking at the actual price they would allow for a drug, this this would be would allow other countries to basically figure out the price that Canada and purchasers in Canada were paying for the drug. So, Professor Morgan.
Yeah, so you've bundled a couple of questions, and I appreciate that because I literally have to run after this. And so very quickly, PMPRB's net of rebate price restrictions on economic analyses would not necessarily disclose the final prices in Canada because they set a maximum price that the manufacturer could ask payers in Canada to pay. Payers might well negotiate even lower prices. The fact that these medicines at very high price sticker prices are covered in other countries is certainly a reflection that those countries are getting rebates. My own research shows that those rebates are often more than 50% off. And for very, very expensive drugs, they can be on the order of 80 to 90% off of the list price. So internationally, everyone knows this is happening, but we don't know the exact number. So the regulations are not going to disclose corporate secrets globally. In terms of investment in patient organizations, Ted Marmer, a famous political scientist who studied health policy in the United States, used to use the line that nothing that is regular is stupid. Manufacturers make investments in patient organizations when they need to pursue particular aspects of their overall PR strategy. Some of that is goodwill, and some of that is providing resources to voices that can help them build their case. If those voices turned against the manufacturer and were as vocally critical of the manufacturer as they are of the drug plans that might not want to pay the price that's being asked for, I think you'd find that the resources or the funding for the charities would dry up. Again, I'm very sorry to the committee and to the chair. I must go. I've got to get across town to a specialist appointment. So thank you, and good luck with the rest of the hearing.
Ms. Grover, then,
thank you, Doctor. Thank you, Doctor. Your time is up, and thank you, Dr. Morgan. I appreciate your time with us. We now go on. On va maintenant à Monsieur Thériault.
We now move to Mr. Thériault. Go ahead, Mr. Thériault. 2.5 minutes, please. In response to Mr. Van Bynen, I would invite him to read page 3 of the brief from Research Canada on the question of investments from the government. They say, we are of the opinion that if we don't do things as we must, we could compromise the government's historic investment in research and innovation, undermine an increasingly dynamic research environment in health, and a high-quality job market, and restrict patients' access to drugs that could change their lives. This is not industry saying this. These are people who do basic research. So we need to find a compromise somewhere. And what they recommend to do things properly is first, push back the date of July 1st to wait, and then to establish a discussion table with partners to find points of agreement for the rest of the process. So if we say we'll push it back and we'll put forward what is a matter of consensus, and then we look at the list of countries, and then we bring all stakeholders together, patient advocates, people from life sciences research, as well as CIHI, APP, PMPRB, those who would really want to discuss and consult this time, and people from the pharma and bio industries who would be against that. Don't you think that would be the solution? When we have this disorder and this distortion of points of view and reports and people criticizing their other people's intentions, do you really think we'll get to something good unless we do what I just suggested? And I'm echoing Research Canada on this. What do you think of this, Mr. Levesque? Would you be interested in sitting at a table to discuss this? Ms. Grover? Ms. Batt said no. But would you be interested in doing that? Would that be a good solution? Yes, it's a solution. Earlier I said the list price is one thing. I've heard consensus that we are paying too much for drugs in Canada. Okay. I'm a taxpayer like anybody else. I'm not against good things. But the important thing is the price paid by the provinces negotiated. And when we can sit at the table and be creative, I think what we've heard is that we can look further for more ideas to be creative. And I think that's what we need to do. But having a reform that gives us a list price that's 50% of the American price because we're changing the basket of reference, well, I don't know how that will resolve anything because it's a list price. Thank you, Mr. Tedio. Ms. Grover, are you in agreement?
Vous avez le droit de dire oui.
You can say yes or no.
Yes, oui.
Merci.
Oui, merci.
Thank you.
Oui, vous
Mr. Tedio, you're missing important partners, the provinces.
Now, Mr. Davies, Mr. Davies, please go ahead. 2 minutes and a half.
Thank you. When we undertook the study, the analysts from the Library of Parliament told us this about the PMPRB. It is an independent quasi-judicial body whose mandate is to regulate the prices of patented prescription and non-prescription medicines to ensure that the prices are not excessive during the period of market exclusivity. It does not have a mandate to set the prices of patented medicines sold in Canada. Dr. Batt, to you in a joint written submission to the committee, you said when independent stakeholders and industry representatives hold divergent and even diametrically opposing points of view, the PMPRB's responsibility is not to strike a balance between the demands of industry and policies that serve the public interest. The PMPRB's role is to come down firmly on the side of the public. It is not to protect the payers, and it is definitely not to make concessions to an industry that's far too powerful. I wonder if you can expand on what you think the role of the PMPRB should be.
Yes, I see the PMPRB as a consumer protection organization, and traditionally, and I've worked for a consumer protection organization in Quebec, where I was one of the editors of their consumer protection magazine. The concept of a consumer protection organization is that industry is very powerful. Individual citizens are not particularly powerful, and they need the government to step in and take their side when there's a contest between a powerful industry and the public interest.
Thank you. And just I guess a very quick question then. Given that I think there seems to be broad consensus that prices are excessive in Canada, and given that it's the PMPRB's job to regulate that, and they clearly haven't been, what do you think of the latest PMPRB reform? Should we go ahead with them or not?
Yes, we recommend that the reforms go ahead, and they've already been delayed twice, so I hope they're not going to be delayed again.
Thank you. I also just want to make just a brief comment, if I may, that I think it's important. I'm starting to hear more and more that healthcare is a provincial responsibility. That is actually not correct. The Constitution of Canada in 92.7 gives to provinces the establishment and maintenance and management of hospitals and asylums. And actually, constitutionally, healthcare is a shared responsibility according to the Supreme Court of Canada. So I think it's important that we remember that. It's very important roles for both the federal government and the provinces. It's not exclusively provinces. Thank you, Mr. Chair.
Thank you, Mr. Davies. So we did get started late, and I've made allowance for that. We used up our hour and a half pretty much for this panel. So I'd like to thank all the witnesses for sharing with us your time today and for sharing with us your expertise and helping us with our study. And that being said, I now suspend so we can bring in the next panel. So thank you all. So welcome back, everyone, to meeting number 41 of the House of Commons Standing Committee on Health. The committee is meeting today to study the Patented Medicine Prices Review Board's guidelines. So I'd like to introduce the witnesses at this point. From Innovative Medicines Canada, we have Pamela Freilich, President. We have Declan Hamel, Vice President, Legal, Regulatory Affairs and Compliance. From the Institute of Health Economics, we have Dr. Christopher McCabe, Chief Executive Officer and Executive Director. And from Live a Little Foundation, we have Aaron Little, President, and J. Scott Wees, Professor. I will invite the witnesses now to present their statements. Just as a matter of procedure, when you're nearing the end of your time, I'll display a yellow card. And when your time is up, I'll display a red card. When you see the red card, you don't have to stop instantly, but do try to wrap up. So thank you very much. And with that, we will go to Innovative Medicines Canada for 6 minutes. Please go ahead, Ms. Freilich, I presume.
Yes, thank you. Pardon me, I've been sitting here listening, the voice is gone. Mr. Chair, honorable members, thank you for the opportunity to present today. I'm joined, as you've just heard, by Declan Hamel, our Vice President for Policy, Regulatory and Legal Affairs. We are here on behalf of Innovative Medicines Canada, which represents 47 member companies from the innovative medicines and life sciences sectors. The pandemic continues to underscore the importance of innovative medicines to the health of Canadians. Most importantly, it is demonstrating why timely access to innovative treatments and vaccines is so critical. It's also one of the reasons we are calling on the government to suspend, for the duration of the pandemic, the implementation of the Patented Medicine Prices Review Board's regulatory changes, which are set to come into force on July 1st. The government has previously cited COVID-19 as a primary reason for delaying the implementation of the PMPRB's regulatory changes. I think we can all agree that the same rationale applies today. More importantly, delaying these regulatory changes will also ensure we all have the time needed to reevaluate the desired policy outcomes, the effectiveness of the consultation process, and the premise on which the PMPRB's new regulations were developed. Since the changes were first proposed, there's been a strong consensus among industry representatives and many stakeholders that the consultation activities were not intended to inform decision-making. From initial steps, which included a 2018-19 steering committee and working group, through to later stages, many points of concern were raised and disregarded. The lack of meaningful engagement led industry to undertake serious actions, including 2 federal court legal proceedings and a constitutional challenge in Quebec. And most recently, in a submission to the Quebec Court of Appeal, the Attorney General of Quebec submitted that the proposed PMPRB changes infringe on provincial jurisdiction, and therefore all the regulatory changes should be disallowed. Providing the appropriate time and process to consider any PMPRB regulatory changes will also ensure that any decisions are based on accurate understanding of where Canada stands regarding the price of medications compared to other key countries. Contrary to PMPRB's assertions, Canadian drug prices are in the middle of the current list of comparator countries, not at the top. Overall, median international prices were 16% higher than Canadian prices. Increases in the annual Canadian price of patented medicines have been, on average, less than the rate of inflation as measured by the Consumer Price Index. Further review will also demonstrate that the price of innovative medicines is not the primary cost driver for Canadian public and private drug plans, as PMPRB claims. Rather, increased drug use by Canada's aging population and the related growth in chronic diseases are the primary cost drivers, not the price of medicines. And though the need for Canadians to have access to the most innovative medicines and vaccines is clear, the PMPRB regulatory changes will impact the market incentives that encourage early access availability in Canada. Information obtained through an access to information request shows that PMPRB's analysis concludes that prices for certain medicines will drop between 90 and 99%. There is a point when price reductions make it not commercially reasonable for companies to introduce drugs for approval in Canada, or alternatively, they will be introduced significantly later. This was already an issue in Canada. Independent data sources show that Canadians only have access to 48% of all new medicines launched globally, which is behind countries like the UK, Germany, Japan, France. This gap in access will increase if the proposed PMPRB changes proceed. Additional time to consider PMPRB regulatory changes will also provide an opportunity to reflect on the true breadth of the Canadian biopharmaceutical sector's economic contributions. According to a recent report from Statistics Canada, the sector generates almost $15 billion in economic activity, $2 billion annually in R&D spending. Calculations based on these data set the industry's R&D to sales ratio at 8.8%, which is more than twice as high as that reported by PMPRB, which uses a 1987 definition of research and development. Now, to be clear, our industry is not opposed to modernizing PMPRB, but believes it can be done in a way that maintains patient access to new treatments and medications, builds on Canada's talent and expertise, and attracts international investment. A vibrant life sciences sector in Canada starts with clear and balanced policy objectives. We believe a whole of government approach involving Health Canada, innovation, science and economic development, finance, and international trade is essential. It also includes fair and accurate reporting on patented medicine pricing, on understanding the real cost drivers to the system, and prioritizing the value of saving lives. IMC and our international counterparts remain committed to working with the federal government and all stakeholders. Our global CEOs have reached out to the Prime Minister on several occasions over the past 3 years, hoping to engage in collegial and collaborative dialogue, and to this day remain keen to develop a productive working relationship. Thank you for this opportunity to speak with you today. I respectfully request that the committee recommend that the government delay the implementation of PMPRB's regulatory changes. We look forward to answering your questions.
Thank you. We go now to the Institute of Health Economics. Dr. McCabe, please go ahead, 6 minutes.
Thank you, Mr. Chairman. Honourable members, it's a privilege to be able to address you today. Canada spends over $15 billion on pharmaceuticals each year. Therefore, how we decide prices is a crucial issue of public policy. And I think it's useful to identify the principles that should guide public policy in this space. The first principle I would propose is that governments do have a responsibility to pursue good value in how they spend taxpayers' dollars. The second is that all Canadians are equal before the law. And the third is that we here in Canada look after our neighbours. The new PMPRB regulations consist of two components: the revision of the reference price basket of countries and the adoption of a form of value-based pricing for some drugs. I view the first change as uncontroversial. It ensures that Canadian prices will remain in line with our economic peers, most of which receive larger industry investments than we do. The removal of the US from the basket is reasonable, given that the US is recognised as a global outlier for pharmaceutical prices, and its prices drive significant access problems in their own country. Given the remaining reference basket countries have very good access to pharmaceutical products, any changes in the supply of drugs to Canada after the implementation of the new regulations cannot, I would argue, credibly be attributable to a reduction in our prices. The adoption of a modified value-based pricing for Category 1 pharmaceuticals is more controversial. Patient groups are legitimately concerned that innovative drugs will not be brought to Canada, and the pharmaceutical industry has raised equally legitimate questions about its impact on investment in developing future innovative therapies. In its pure form, value-based pricing is a way of operationalizing the principle of equality. Value-based pricing does is it sets the price for a product to ensure that the health gained from buying the product is at least equal to the health lost by other Canadians that results from diverting healthcare funds from their current activities to pay for it. The importance of caring for our neighbours drives a divergence from this pure form. The PMPRB's version of value-based pricing will sacrifice equality to ensure patients in need can access highly effective, innovative treatments. For breakthrough treatments, the PMPRB regulations will establish prices that sacrifice at least 6 years of good health for other Canadians for each year of good health the new innovation produces. Now, it's legitimate to ask whether this 6-to-1 trade-off is sufficient to attract investment in developing future innovations. By setting a value-based price, the PMPRB, essentially on behalf of Canada, is signalling to future investors our willingness to pay for future products, which they will take account of. Is the proposed value-based price sufficient to encourage investment to address unmet needs? Dr. Aidan Hollis of the University of Calgary evaluated the recent highly effective innovative therapies for cystic fibrosis to examine whether the prices the manufacturer would like payers to pay were required to achieve acceptable returns on investment. And his detailed evaluation established that standard pharmaceutical industry target returns would have been achieved with prices approximately 1/10 of those that the manufacturers wanted to charge. The evidence does not support the concern that the implementation of the new PMPRB regulations will impact upon investment in the development of novel pharmaceuticals. The PMPRB is concerned with protecting Canadians from excessive, as distinct from abusive, pricing. Value-based pricing is a robust operationalization of the concept of excessive. When we spend over $200 billion a year on healthcare, the idea that the price for any single technology is unaffordable is not credible. Excessive can be operationalized by considering whether what we have to give up to pay for a new drug is justified by what we gain. As a starting point, giving up more than you gain is excessive unless there are extenuating circumstances, hence value-based pricing. Having a conceptually robust operational definition of excessive strengthens PMPRB's processes and provides greater certainty for manufacturers and investors. The revised regulations are consistent with important.
Pardon me, Doctor. I've stopped your time.
Sorry, did I miss you?
No, it's fine. I just want you to ask you to raise your mic to about the level of your upper lip. You're getting a lot of popping and so forth.
Sorry, I apologize.
Very difficult for speakers. Maybe a little bit more.
A little bit more than that? How's that?
I think that's good for me. Perhaps the clerk could verify this with the...
Is that fine?
Up and it's a bit too close, so...
A bit further away?
Should be okay. So
is that okay to everybody?
Okay.
I do apologize.
Well, that's okay.
Okay, are we good to go? All right. Sorry, Doctor. Please carry on. I shall resume your time at this point.
There's no point if you can't hear me. The revised regulations are consistent with important Canadian values of value for money, equality, and caring for our neighbours. The available evidence, whilst limited, does not support the concerns that change in the return on investment will damage investment in future innovations. And the experience of countries in the reference price basket in accessing innovative pharmaceuticals does not suggest that Canadian patient access should be impacted by price reductions. There may also be benefits for industry and patients. Aligning PMPRB's regulations with the methods used by payers to evaluate drugs should expedite the currently lengthy price negotiation process, allowing companies to products more time on market with reimbursement. Further, the downstream pressure on prices will strengthen companies' incentives to be more efficient in development, manufacturing, and marketing of their products. Companies who can always pass costs onto the price-taking consumer unlikely to be as efficient as those that cannot. In addition, the downward pressure on average prices will allow payers to provide coverage for more drugs for more Canadians from the same limited resources, and in the longer term should reduce the cost of prescriptions for Canadians. Thank you, and I'm happy to answer any questions.
Thank you, Doctor. We'll go now to Erin Little, please. Go ahead, 6 minutes, please.
Mr. Chair and members of the committee, thank you for the opportunity to appear before you and share my personal views about the Patent Medicine Price Review Board and my personal experience as a rare disease advocate. My name is Erin Little, and I'm the president and co-founder of Live a Little Foundation. Live a Little Foundation was founded in 2013, 2 years after our daughter Olivia was diagnosed with the rare disease cystinosis. We are a volunteer-run organization committed to supporting the advancement of treatments and ultimately a cure for cystinosis. Persispi is an excessively priced drug that was flagged by the PMPRB in 2017 and a perfect example of how the PMPRB protected patients. I provided you with the PMPRB statement of allegation regarding Persist-B. The Cystinosis Research Foundation funded every bench study in early clinical trials at UCSD, which resulted in the development of slow release form of cysteamine. In 2016, Raptor Pharma was bought by Horizon for $800 million. Persist-B is the result of a business deal, not R&D. How many other companies are using the same business model to build their portfolios? As members of Parliament argue about the PMPRB spending $56,000 to invest in an effective communication plan, I would recommend they be more concerned that in 2020, Horizon CEO raked in 21.63 million USD, which is more than the PMPRB's annual budget. And let us be honest, the PMPRB can use all the help they can get when it comes to educating patients and Canadians on what and why they do what they do. In 2019, Recordati brought the new non-patented drug Cystadrops to the Canadian market with a sticker price of $120,000 a year. No patent meant no protection from the PMPRB review board. Cystadrops is another example of taking an old drug, tweaking the delivery mechanism, and marking it up by 4,000%. Recordati's GM and I were discussing the price, and he admitted the drops would be expensive, and then proceeded to tell me, all we're asking is a little bit more from each taxpayer to cover the cost of a small population of patients. I sat there in dismay for two reasons. One, I was in shock that pharma priced drugs based on what the market will bear and not what it costs to make them. And two, I am one of those taxpayers. What are we going to do about this? Are we printing money to continually pay for high-cost drugs? Because if we are, then let's print it for clean water, for the 250 bodies just found, for the homeless, for the kids who go to school hungry, for mental health services and LTC homes. When we pay for excessively priced drugs, the money needs to come from someplace, which means someone else goes without. But if and when we hold Big Pharma accountable and charge what the drug is worth instead of what the market will bear, we all win. We are all familiar with the term grooming when it's referenced to sex trafficking children, but no one is yet talking about how pharma is grooming advocates. Grooming is when someone builds a relationship, trust, and emotional connection with someone so they can manipulate, exploit, and abuse them. In November 2017, Horizon Pharmaceuticals invited us and a select few Canadians to a roundtable meeting. The meeting wasn't about our concerns. It was about building a common advocacy voice shaped by Horizon. I have provided you with the agenda from that meeting along with a letter of intent. That meeting is an example of grooming patients. Horizon has also created the platform Rare Is on Instagram. Rare Is gives patients, advocates, and families a place to share their stories and be heard. This is a perfect example of building trust and emotional connection with vulnerable advocates that leads to manipulation and abuse. The repercussions of these relationships means advocates turn against our government. In October 2018, I sat at this table and heard what it would cost to keep Olivia alive based on the average life expectancy at that time. It was hard to hear this as a mother that wants nothing more than to outlive her child. I also understand why she had to bring that cost to the community's attention. High-cost drugs are not sustainable in our healthcare system. I want to share with you the current costs faced by two different families living with cystinosis. Family A, Persist-B costs $56,000 a year and Cystadrops $120,000. Family B, Cystagon, costs roughly $18,000 a year and compound drops just under $3,000. All four of these drugs are made with cysteamine. First evidence regarding the therapeutic effect of cysteamine on cystinosis dates back to the 1950s. The delivery is changing, but not the ingredients. Is the change in the delivery mechanism worth a 4,000% increase? In conclusion, I support the implementations of the new guidelines, and I strongly suggest we look harder into advocacy groups that are funded by industry and question if they are being groomed by the industry. I strongly believe every patient deserves to access drugs that are safe, effective, and affordable. Health Canada needs to do a better job listening to the patients, caregivers, and organizations not funded by pharma. We once trusted our child's life in the hands of a Canadian organization, only to be betrayed as their agenda was to support the industry. This organization happens to receive funding from both pharma companies treating cystinosis patients in Canada. I will end with this. I am not against for-profit companies, but I am against the greed, manipulation, and control they hold over the lives of every Canadian. Our child, like many others, would die without access to these drugs. I remember the days when I feared if Olivia would live. Now I fear if she will be able to afford to stay alive. Thank you, and I'm willing to answer questions.
Thank you, Ms. Little. We'll start our round of questions now. I believe we start with Monsieur D'Entremont.
Thank you very much.
Go ahead, please. 6 minutes.
Thank you very much, Mr. Chair. Where do we go from here? PNPRB has been around for a while. We've been talking about it on our first run around. We had some very good testimony here today. Very emotional, Aaron, Ms. Little. Thank you so much for your presentation on that as well. It's hard to figure out where to start on this one. Maybe the quick question here is a lot of concepts are getting caught up in our discussion here. We got expensive drugs, rare diseases, so the rare disease strategy issue that we need to be talking about. I don't know if it belongs in here. It does, but it doesn't. We have the issue of pricing. That belongs in here and it doesn't. We have the issue of this pharmacare that's been promised to Canadians on a number of different occasions. That's caught up in here. So, it's hard to quite figure out. So some of the things that we keep hearing, and maybe this is to IMC for a few minutes. Where do you think things should go from here? If the government has already held back 3 times or 2 times on expanding the regulations, on holding back, I'm trying to figure out how to actually ask this question correctly. Do we hold them off again? Because I'm sure by holding them off twice now has created even more challenges within the system, because the system is probably very anxious on how pricing is going to happen, how the reviews are going to happen, how PNPRB is going to work. So is holding it off for another 6 months conducive to the companies? And maybe that's the first question to Pam.
Through the chair, thank you very much for that question. I apologize for my voice. I don't know where it's gone. It's not about delay for delay's sake. It never has been. Who let the dogs out? But it is about reaching a better outcome than we feel is possible through the current regulations being proposed. So without taking up time on this call, I have a pile of correspondence that has gone in to ministers, to the Prime Minister, from ourselves at the association, from our global CEOs, requesting that dialogue. We believe, as Mr. Levesque mentioned in the previous session, that better solutions are possible. And so that to me is what the delay is about. It's to have that time, especially with this kind of a hearing that this committee is so generously offering us to those of us interested in this issue. Let's truly get to that discussion that will lead to a better outcome than what is currently on the table.
Simple question, are drug prices too expensive in Canada?
I'd love to quote some data back to you from PNPRB reports, because I think there's a bit of a discrepancy between some of the sound bites that you might hear versus the data from the actual reports. So three comments I could make. That only 3 of the current basket of countries have prices below Canada. The price difference is quite minor. The second point would be that relative prices have declined over time. I mentioned this in my opening comments. Prices in Canada have been around 20% below the median of the PNPRB 7 for the past 3 years. It's the lowest they've been in the history of the PNPRB. And the last comment I would say is the PNPRB says that US prices are a global outlier, makes Canada's prices appear lower than they are. However, even when the prices are only compared to European countries in the PNPRB 7, Canadian prices are still in line with that median, and that's according to the last 5 PNPRB annual reports. So you can argue, do we still want them lower? That's another question. But in terms of what you've heard through the media and statements from PNPRB, I would just add that additional information.
Maybe the last question to Dr. McCabe, because I'm going to run out of time quickly. When we talk about the value-based pricing, so try to expand a little bit on that. I mean, we have what the listing price is, we have what the sale price is, we have this whole negotiation that goes on in between. What can patients actually pay, or are we still continue to be worried about what provinces can pay or what plans can pay? Like there's a whole bunch of different payers. Who do we actually work with here?
Okay, I think it's really important, and what I've focused on is the PMPRB is setting this maximum price. Okay, and it's the only location where the whole of Canada can actually have a conversation about good value and value for money. And so once the PMPRB maximum price is set, there is then all the payers and the HTA and all of that comes into play. It's not part of this discussion, to be honest. So if it helps you not to say, okay, let's just talk about, is this a way of establishing a price that is not excessive? Because that's its function. And as I tried to outline, using value-based price is a nice way to operationalize that concept of excessive. And then once you've got non-excessive, then the rest of the market can work as it does currently. I'd hope it doesn't, because I think there are much bigger efficiencies for industry, patients, and health systems by dealing with the fact that it's 18 months to 2 years, typically from a Health Canada approval to actually a reimbursed invoice. I think there's much bigger gains to have by re-engineering that process. But Canada as a whole does need an operationally robust definition of an excessive price. And I think that's what this is about. And if we can all focus on that, it will help us, I think.
There we go, what, 40 seconds left there? Maybe 30? There we go. You're on mute again.
Sorry, you're finished. Thank you very much. We go now to Dr. Pawlowski. Dr. Pawlowski, go ahead, please, 6 minutes.
My questions are for Professor McCabe. Now, in the previous panel, we heard from Cystic Fibrosis Canada, a group which has strongly advocated for us to drop the proposed changes to the PMPRB. Let me ask the same question I asked somebody on the previous panel. Are some drug companies, in your opinion, using patient advocacy groups in order to further their own financial interests, and are at least some drug companies, by refusing to apply for Health Canada approval, as Vertex was doing for some period of time, not holding sick Canadians hostage to their demands, and certainly part of their demands are they don't like the changes to the PMPRB. So that's one question. And now I'd like to get the second question in case your answer to the first one is overly lengthy. And that is, what can we do when companies refuse to ask for Health Canada authorization for drugs which are life-saving? And what can we do in the example that Ms. Little gave, when a drug which is no longer under patent, however, the drug company's asking for really excessive prices, what can we do? And I would suggest that in TRIPS, the agreement on trade-related aspects of international property, there is a realization that intellectual property rights shouldn't trump all other human values. And as a result, within the TRIPS WTO agreement, there are the TRIPS flexibilities, and one of the TRIPS flexibilities is compulsory licensing, which allows the government to give a license to a non-patent holder. They do have to compensate the patent holder. But in your opinion, when we're getting kind of predatory behavior from some drug companies that would seem to be holding Canadians hostage, should we not reconsider reinstituting legislation which would allow us to do compulsory licensing? Thanks, Professor.
I'll try to be quick. To your first question, pharmaceutical companies are doing exactly what we asked them to do. We have set up society and asked them to maximize their profits, and that has a lot of good things about it. They're doing what they want, what we asked them to do as a society. If we want them to do different things, we should change the legislation. They have a coincidence of interest with patient groups, at least in certain forms, and so some patient groups choose to work with them and others don't, and I think that's their right, their right of free speech, and I'm not going to judge them. I think all of us have probably had people in our family who we've lost too early or in horrible circumstances. I'm not going to judge those things. So I think people are exercising their rights of free speech and doing what we ask them in looking to maximize their profits. We just need to recognize that. It's what we're dealing with. Second question, which is about the role of compulsory licensing. I think compulsory licensing is, it's there as a protection for when the system fails. And therefore it has to, and sometimes the system does fail. And sometimes governments have to be willing to use it to create incentives for people and stakeholders in these sorts of processes to engage effectively and to find solutions. And I do believe, that if there is the system is abused and there is no willingness to move away from that abuse by the patent holder, then it is within government's right to use compulsory licensing. But I think whenever that happens, it's a proof that the system has failed, and we should be looking to find out why the system failed.
Well, would you suggest in response to Ms. Little's point in the price that the drug company is asking for the treatment for her daughter's cystic cirrhosis, the system would seem to have failed if they're asking $100,000 and there's nothing we can do about it? Is that, and for example, with Vertex, if Vertex was not bringing the drug to market, does that not suggest to you that the present system is failing?
I would say that both of those are credible examples of the system failing, and the government should take seriously its responsibilities to its citizens, and certainly entertain the use of it. The UK government did entertain the use of its rights around a very expensive breast cancer drug, and that helped to trigger a negotiation that otherwise may well not have happened. So these are tools that are there for a reason and that are used sparingly but effectively. And I wouldn't criticize anyone who used them in both of the two cases that you identified.
Pardon me, doctors. I'm going to stop your time, Dr. Pulaski. Dr. McCabe, could you move the mic a little bit further away from your mouth? We're getting a lot of popping. It is really harmful to the interpreters to try to deal with that. So
is that better?
Say a few things and tell us about the
weather. I feel like I've talked enough already, but is that better?
To my ear, it's better. I'll look for a wave from the clerk to see if it looks good.
Yes,
a little bit further. Sort of come see, come saw.
I'm sorry to be such a troublesome witness.
Well, it's not you; it's your mic, I think. So let's forge ahead as we are. And Dr. Pulaski, you have I think 1 minute left.
Okay, so we had a witness in the previous panel who suggested the results of these changes to the PMPRB. He gave the comparison and said, what's going to happen? It's going to be like Tesla can get $100,000 for its vehicle in the United States. Canada they can only get $50,000 for the same vehicle. So why is anyone want to sell in Canada? We've also heard, and I think on this panel, two people talking about reductions in profits by 90 or these will result in a reduction in their asking price from 90 to 92%. Professor McCabe, with those particular examples, is that this legislation that draconian that's going to cause such a loss of profits for pharmaceutical companies?
Okay, I think it is a very strong set of regulations, and I think we need to remember that old saying that hard cases make bad law. There will be extreme cases where the mismatch between the price that is asked and the value that is delivered is very, very large. We have to ask ourselves, do we want to pay massively over values? Do we want to sacrifice a lot more of other Canadians' health to avoid these reductions in revenues? You only get that if actually the expected value, how it impacts on patients' health, is completely out of kilter with the price that the manufacturers are asking to be paid. So if you are out of kilter on your ask, you will see a very large reduction. But that's not necessarily a bad thing, because I don't think any of us want taxpayers' money to be paid for low value technologies, which is what will be the case in that circumstance.
Thank you, doctors. Nous allons maintenant, Monsieur Thériault. Monsieur Thériault.
We move now to Mr. Thériault. Mr. Thériault, go ahead, please. 6 minutes. Thank you, Mr. Chair. We are faced with a situation where there are people who claim that the reform needs to go ahead as is and that pharmaceutical companies are bluffing. They won't leave. Clinical trials will continue. And patients, even if there's no strategy for innovation, even if we separate health, innovation, research and development, even if we still don't have an up-to-date strategy for rare diseases, some people think there will be no impact. Some people think there are risks, but I would like to hear, Ms. Freilich, what does Canada represent in the global market? Let's talk about Vertex. Well, people have talked about it, but they could not do clinical trials here and will have access to those medications 6 to 8 years later. Isn't that right? People won't be able to point a finger because it's a free market globally. Am I incorrect?
Merci pour la...
Thank you for the question.
Sorry, I'm getting translation in my ear now. Just have to check. So to the honorable members, je vais répondre en anglais si ça...
I'll answer in English if it doesn't bother you.
Il y a un problème de traduction.
There's an issue with the interpretation. Are you on the English channel?
Yes, I'm going to speak in English. I haven't changed my channel from before, so.
I'll stop the clock here for Mr. Thériault. You can put the translation on whatever channel you want to hear, and then you may speak in whichever language you wish. The translators will translate accordingly. But what language you want to hear is what you should have your English.
Yes. Yeah,
Go
it's
ahead.
been fine up until now. I'm not
Monsieur
sure.
le Président, est-ce qu'on peut...
Mr. Chair, could we start over again? What is Canada's weight in the global market? Can we really think that it's bluffing from the pharmaceutical companies that there will be fewer clinical trials? That is my question.
So there are many elements to your question. We already lag behind our international peers in terms of the numbers of new products launched. So this would be my first point. We find that it's critical the PMPRB does not further erode Canada's status in that global market. At the moment, Canadians only have access to 48% of all new medicines launched globally, and that compares with, say, 64% in Germany, 60% in the UK. We've talked about that before, and of course more in the US. Only 25% of all medicines are available in Canada within the first year of international launch, compared to, again, much lower percentage a higher percentage in Germany, in the UK, in the US. And there's also a time lag that has been referred to, and I'll just include that in my commentary because you're asking about the international status of Canada. And Canadians wait an average of 17 months from the first international launch, whereas medicines are available far, far sooner in other countries, 11 months in Germany, 12 months in the UK, 4 months in the US. So we're already at a disadvantage. What I wanted to say, though, and you asked specifically about clinical trials, but if there's time, I'll add a little bit more, is that the industry, first of all, is extremely important to Canada in terms of its support of clinical trials. Between 65 and 75% of clinical trials initiated in Canada every quarter since 2015, they're sponsored by industry. And according to the data that we have been collecting, there's been a decrease of about 20% compared to the previous 3 years in clinical trials being launched in this country. Now, some of that might be due to COVID. I know someone would raise that point, but we're looking at data across quite a period of time. And I have other data points on impact, but I will stop there in deference to your question.
Vous avez fait allusion dans votre présentation.
During your presentation, you referred to an ineffective consultation process. You're not the only ones. That's a claim that's been made by a number of stakeholders. And you've indicated that the die was already cast, that the reform was already determined ahead of time. What makes you think that everything had already been decided ahead of time? I know there were 2 delays. I've understood you don't want a third one without a consultation table being planned, because pushing it back 6 months to just push back the uncertainty for 6 months doesn't amount to much. So what do we need to do, in your opinion?
Au niveau du procès.
Regarding the process.
In the process. I want to just recall something that I heard from Treasury Board Secretary Peter Wallace early in his tenure when he was appointed to that question. And he talked about how important it is for government not just to listen and walk through a consultation process, but to hear. And that is the piece that we all feel has been missing in this process. We cannot state that the number of steps haven't been taken. They have, but we have not been heard. I did submit a letter early in the process, which I can make available to this committee, that outlines the numerous concerns we had with process and why we felt we were not being heard. But perhaps the most compelling data point is that 80% of 112 submissions to PMPRB's most recent consultation are opposed to or have expressed concerns with the guidelines, and yet minimal changes have been made over the course of the 4-year process. Thank you.
Est-ce que j'ai du temps supplémentaire?
Do I have time left, Mr. Chair?
Vous êtes sur mute?
You're on mute, Mr. Chair.
Désolé, monsieur.
I'm sorry. You have 10 seconds left, please. I'll let those 10 seconds go, Mr. Chair. I'll come back for the second round.
Merci, monsieur.
Thank you.
Now to Mr. Davies. Mr. Davies, go ahead, 6 minutes.
Thank you. Ms. Little, first of all, thank you for sharing your very personal experience and best wishes to your daughter. Ms. Little, you made reference to the fact that the molecules involved in the medicine that helps your daughter was discovered in the 1950s. And it's, if I understand correctly, it's all that changes is that a pharmaceutical company takes the same molecule and changes the delivery system and then charges, if I may say, an outrageously expanded amount of money for that. Can you just explain that in detail to us?
Yes. So the active ingredient cysteamine is in all 4 of the products that I previously talked about. And the product cysteamine, that is the hardest part of, I think, almost any treatment, if you ask any patient, are the side effects. And the side effects are of cysteamine are from all drugs. So when they took Cystagon and turned it into Procysbi, Cystagon has to be given every 4 hours and Procysbi has to be given every 2 hours. Now, I wholeheartedly support that this drug is here in Canada and Canadians have access to it, because if Olivia was a 26-year-old woman managing relationship career, of course I want her to have a drug that makes compliance easier. The problem is that the side effects are all still the same. Gastro upset, the drug makes our children smell and patients smell, and just loss of appetite, poor appetite, gas, bloating, and just horrendous things that nobody wants to deal with. And so with the difference between the Cystagon and the Procysbi was they enterocoded it so it releases differently. Is it worth that? That's not for me to decide, but a drug, an active ingredient that's been around for decades and was first introduced as a treatment in 1994 for patients, I find it unjustifiable. And
what was the price difference between that change?
So the drug is based on weight. I just have to point that out. The 2-year-old who takes Procysbi for $56,000 a year versus Olivia, who takes Cystagon at $18,000 a year. So if Olivia was on Procysbi, she would have to take a higher dose, which would result in more money. The compounded eye drops that have been safe, effective, that have been on the market for years are $3,000 a year, and the new drops are $120,000 a year. And again, they do offer easier compliance, but the drug is still the same.
And I understand you had some concerns about clinical trials. Can you explain to us what your views on clinical trials are and the importance of that?
Yeah, and I'm going to speak only to our rare disease because it is the only disease I represent. We are very fortunate that a cure is on the horizon for cystinosis. In 2019, a clinical trial opened to use gene and stem cell therapy to, which again, will hopefully result in a cure. And the clinical trial is in the States, and the pharmaceutical company AvroBio right now is taking the time to take the clinical trials globally. And I know they're in Europe and they're moving to other locations in the States. They are not coming to Canada. I will say, however, that the first patient to actually go through the clinical trial in the fall of 2019 was a Canadian male. So we are still being offered clinical trials. And I think this is where we need to hear from more from patients and to actually to hear the stories of what the words and the numbers mean behind that.
Thank you. Dr. McCabe, approximately what percentage of the money that goes into research that discovers new drugs is publicly funded?
Sorry, that's an incredibly difficult question to answer because...
Sorry, Dr. Morgan told me to ask you. So.
Oh, I'll thank him for that next time we're having a beer, hopefully. I don't have that figure to hand, and it is undoubted that the basic and increasingly early translational work for pharmaceuticals and advanced medicinal therapies are draw heavily on public dollars. I think the vaccines are a fantastic example of the COVID vaccines are a fantastic example of how a great deal of investment from the public sector was then picked up to take through phase 3 trials, which the pharmaceutical industry are absolutely astoundingly good at, but it takes both. And what the proportions is, it varies a lot. So sorry, not a helpful answer.
No, that's good. I'm going to spend a bit of time on the last one because I think Trikafta is a very interesting example for this. And I think every single parliamentarian wants every single Canadian who has access to, who needs Trikafta to get access to it. And that's not happening today. But here's a brief history of it. We know that it was a research team at the Hospital for Sick Children at the University of Toronto that discovered the CF gene in the 1980s. It was the Canadian Cystic Fibrosis Foundation and clinics that identified almost all the research subjects from families in Canada. They donated blood samples. The Canadian Cystic Fibrosis Foundation and the National Institutes for Health supported the research. The CFF gave $150 million to Vertex in 2000 to do the research. And so what happened when the company finally launched the precursor to that, which is Kalydeco, they priced it at $294,000 annually for 2 pills a day. 29 researchers contacted them. They wrote Vertex's CEO to express their dismay and disappointment that this successful drug was diminished by this unconscionable price, in their words. Aidan Hollis, who you referenced, studied Vertex's pricing for Kalydeco and Orkambi, precursor as well to Trikafta, estimates that the company's profits from the 2 drugs will be $21.1 billion. He concludes that the high prices are not justified by costs or the need to support the innovation. The price seems more designed to reward shareholders. My question is what can we do to get Trikafta into the hands of Canadians? And is it time that the Canadian government use compulsory licensing? If this company won't apply to Health Canada to make this drug available, should we exercise our right to compulsory license that drug? And finally, how many times has the Canadian government used compulsory licensing?
I don't know how many times the Canadian government has used compulsory licensing. I think the magnitude of benefit of Trikafta to the Canadian CF population is so large that it would be legitimate for the government to consider using its compulsory licensing power if Vertex persists with not bringing it to Canada. But I would hope that would not happen because it would be a failure of the system.
Thank you, Mr. Davies. So that wraps round one. We will start round two. I believe it's with Mr. D'Entremont. Mr. D'Entremont, please go ahead, 5 minutes.
Thanks a lot, Mr. Chair. And so, I mean, we get to the basis here. Two is expensive drugs, access to certain drugs. So maybe again to Ms. Freilich, you know, how do we make sure that drugs are available and bring down the prices? I mean, that's the two things that need to happen here, is that the drug pricing needs to go down, access of those drugs need to be available to Canadians. Have you made it you know, where's that meet in the middle of where PNPRB is and maybe where pharmaceutical companies are?
Yeah, thank you for that. And we as an industry have pulled together on at least two occasions, I guess what we felt was a good way forward, and have presented this to government. And I know that one of the honourable members of this committee did cite one piece of one of those offers, but it was an isolated piece that was really part of a comprehensive package that we felt would help government meet its policy needs, but again, still ensure that Canadians get access to the drugs that they need. But the government has not expressed an interest in that, which is why I continue to come back to my plea, if you will, and my most compelling point is that there needs to be a dialogue, not just with industry and governments. Fully support having patients part of this. It has been part of our mantra over the last couple of years.
So, you know, within it we should have a table, some kind of place where PNBRB can be a listener. They can chair the meeting, whatever we want them to do, but to bring these different folks to that table. Who should be at the table? I mean, patient groups, you're saying, pharmaceutical companies, who else should be there?
Well, the whole of government needs to be there, and I did reference that in my opening comments. So at the moment, we are, PMPRB is within the health umbrella, and so everything we do has been put over to health. Whenever we write to another department, it is sent over to health. So we're stuck with the struggle between dealing with the cost containment debate with Health Canada. On the other side, with ISED, in Industry Science Economic Development, we have a wonderful report that was done in 2018, HBES, the Health and Biosciences Economic Strategy Table. We have a more recent one done a few months ago, the Industry Strategy Council, all of which promote the life sciences as an economic driver for the health and well-being of Canadians. So we're struggling as an industry, working very positively, Minister Champagne and others over the years, Minister Baines, to try to encourage investment to come to Canada. But the cost containment policies really make it difficult for our CEOs to compete at the global level.
People at the table should include provinces as well. I was a provincial minister. A lot of times we had an opportunity to help set prices or purchase different kinds of drugs. Avastin was one that happened during my time. You know, it was a few $1 million that we had to make a decision on where we were going on it. We funded it, by the way. But, you know, how do the provinces play in it? Because they're not necessarily a part of PNPRB. They're a part of the other program.
They do pay for the drugs, many of them, so they have a vested interest. We've had wonderful conversations with many of the provinces. Annie Perrault earlier in the session talked about the life sciences strategy in Quebec. We've had very good conversations in Ontario, with Nova Scotia, with Alberta, with British Columbia. You can go right across the country. So I think there's a way to do that. There has to be a will. I think that's the sort of main issue. And as Paul Levesque said, it's the wrong reform for the wrong time too, with the pandemic. Everyone is consumed with the pandemic. So let's start with a coalition of hopefully the willing, and then figure out from there if we're missing anyone at the table.
Well, and even to a point, is there parts of these regulations that you would say you could phase in? You know, we could continue to discuss a few of the more finer points, but there are a number of those recommendations that could actually be brought in immediately.
I think this would be a beautiful start to a conversation. The concern is about the extreme nature of the impact of the regulations as they currently sit. The statistic that was just quoted a moment ago, the 99%, that comes from a PMPRB assessment. It's not an industry assessment. We don't have a line of sight on all of those data that PMPRB has been working with. So let's get to the table and discuss the art of the possible, as opposed to being so estranged and the relationship being, I've used the word not ideal, fractured. You've seen that in the press when I've used that. We can do better.
I'm guessing I'm out of time there. And you're muted still there. There you go.
Sorry, yes, you are out of time. Thank you very much for, you can be co-chair perhaps. Thank you. We go now to Ms. O'Connell. Ms. O'Connell, please go ahead, 5 minutes.
Thank you, Chair. Thank you to all the witnesses for appearing. Ms. Little, thank you for your testimony and sharing your story, your daughter's story. You spoke towards the end of your opening statement about how at first, so forgive me, I'm paraphrasing, but it stuck with me in the sense that at first you thought about, your daughter accessing these drugs to save her life. And then as she gets older, you worry about, can she afford to sustain these life-saving medicines? And that's the piece that I'm often, I think a lot about when we're having this conversation about the fact that this kind of issue around will drugs come here, but I often wonder, even if the drugs come here with outrageous prices, how does that make them any more accessible for the average Canadian unless you're independently wealthy or you start, I see so many GoFundMe pages or, fundraising started for individuals to get some of these drugs. So could you maybe just speak a little bit more about that experience and the availability to even access it, even if drugs do come here?
Yes, and this is something I think that we always think about as a family. One, we're very fortunate that my husband does have a great benefits package. When Cysta Drops came to the market, the insurance company still, laid in the weeds to see if the government was going to cover them before the insurance made the decision. So they just sat and waited. And thankfully, we didn't have to go out with the drug in that time period. And I will say, in Ontario, because each province, as we know, is different, and from what I know, every family in Canada has gotten coverage for cystinosis. And we're very lucky. We're an ideal population. There's only roughly 100 of us. There's not 5,000. It'd be a different story and we'd have a different battle. And I will say that the family A that I mentioned in my testimony, who the Procispi is covered, the eye drops are covered, they have insurance, their insurance package isn't as nice as our families. So a month, because of some of the drugs that treat our children, are not covered because they are supplements, but if they do not get these supplements, they will go into renal failure. One family still pays out $230 a month for these supplements. So it's not always about the excessively priced drug is one thing. And how do I have to raise my child? Do I have to raise my child for her to take a job in a company that just so she gets good packages versus doing something that she's passionate about? I don't think as Canadians that we should have to think of that as a family. She should have every equal opportunity and access to the treatments. She was born this way. This wasn't lifestyle. This wasn't an accident. This is how she was born. And this is why we need to be concerned, because just because Canada covers these drugs now doesn't mean they're going to 20, 30, or 40 years from now. Thank you.
Thank you. And it leads to the fight that even if these drugs get approved, and we look at Trikafta, CF is a good example of this, that even when the drugs, come through that approval process, then the next, like through Health Canada, the next fight is then, our provinces and territories going to cover it, our private insurance going to cover it. And it just feels like even when, drugs are approved for use here, the fight begins of then who's going to pay for it, because, it's so expensive in a lot of cases.
Mm-hmm.
Thank you for that perspective. Dr. McCabe, I just wanted to speak to you about in the earlier panel, if you have a position on this. Will be my last question. That an earlier witness talked about how Canada, the threat that pharmaceutical companies will leave Canada because we're a small jurisdiction if this happens. But she said that Canada is not a trivial market, that although we're not as big as the US, we're certainly not trivial. Do you have thoughts on that?
Yeah, we're not a trivial market. We're certainly not a trivial market when we work pan-Canadianly. No disrespect to Prince Edward Island, but in global terms, its population means some people might describe it as unimportant. But we are tens of millions of people, and when we work together, we are a substantial market that will generate a lot of revenue and profit for companies. And so, given their profit maximizers, I wouldn't expect them to leave. I think there's lots of things that we can do and should look to do complementary policies to make us a better place for companies that are R&D focused to be here, but they're to do with research infrastructure that we don't have currently. The reason the UK does so well and can get away from its low prices is not just that they have domestic global companies, it's also that they have the most amazing research infrastructure. As they showed with COVID, they can run 30, 40,000 patient trials, high quality, at almost the drop of a hat. And we couldn't do that here. So in terms of keeping the companies here, I don't think it's prices. And that's what the literature says. Companies locate on the basis of other things.
Thank you so much.
Thank you, Ms. O'Connell. So we go back to the Conservatives at this point. I'm not sure who. Would it be Mr. D'Entremont again?
I'm just looking, making sure nobody put their name in. I guess that's it. I guess that is me. And I'll share it if one of my colleagues do want to kick in here a little bit too, if they want. So, let me go back to my list. So, the provinces, Quebec, Ontario, we're saying Alberta, have been calling for to hold off the changes to PNPRB again. Where do we think that's going? Maybe again for IMC. I know a lot of these questions for IMC, but they represent the industry. So, where are the provinces and how does that go in?
Yeah, thank you for the question. Just to clarify, when I mentioned Alberta, it was not in terms of supporting a delay in PNPRB. They may or may not. They haven't voiced that to us, but they have certainly voiced an interest in being competitive in the life sciences world. That's the piece that I've noticed. Ontario and Quebec have been very, very active for decades. That's where most of the industry is located. But Atlantic provinces, the conversations I've been having with them, and again, right across the country, reflect that they truly want to be competitive. I'll just add that Canada certainly isn't trivial, but it is only 2% of the global market. And so it's very difficult for us to compete on that stage and bring industry and various other pieces of the life sciences sector here. So we need to be on our A game.
So a lot of the patient groups have said that, some of this research will go offshore, they'll go to another country. It could take a number of years before we see some of these innovative medicines show up for Canadian patients. How real is that threat? Is it a real threat, or is it truly just because of this global market that we seem to find ourselves in?
Well, and I prefer not to use the word threat because none of the companies, none of our members have ever viewed this as a threat, but rather a reflection of the reality of the situation. So I can comment just, quantitatively, because one of the things, an advantage that I have that you don't, and no one in this committee does, because you're looking at lagging indicators in the reports that come out with data that's a couple of years old. I get to talk with these companies on a daily basis. And so while I can't name companies, well, I can one. I'll save that for my third comment, but I can tell you that I know at least 6 planned drug launches by our member companies have been delayed, including drugs for rare diseases, because of the uncertainty around PNPRB. We know that only 15 of 54 drugs that have been approved by the US FDA have been even submitted to Health Canada for approval. And I have a list of 39 drugs, all on rare diseases, that these include, well, not just on rare disease, but cancer, Parkinson's, HIV. They have not been submitted to Health Canada for approval. And it's specifically because of the uncertainty around PMPRB. This is not for other reasons. So that's a quantitative where I can give you a few numbers. Qualitatively, Life Sciences Ontario did a survey of companies and executives just a couple of months ago. 35% say they've already delayed bringing new treatments to Canada. 96% anticipate that these new rules are going to drive decisions to delay or not bring new treatments to Canada. And 90% have said that the reform will reduce research, clinical trials, and innovation. And my last point, if you want a very specific example, it's a letter that has been submitted to this committee by a member company, Medicago, which states very clearly that as a Canadian company, we've all heard about Medicago and are so proud to have a homegrown company. But when it comes to launch, it may not be here in Canada, and it's because of PMPRB. Thank you.
Is it because of the rules that are being proposed for PMPRB, or is it the continued delay of those regulations?
Well, thank you for the clarification. It is the PMPRB regulations, the new regime that is scheduled to come into effect on July 1st in just 3 weeks' time from now. That is what's causing the problem. The PMPRB itself, we are very happy to work with government to modernize it. Interestingly, I might add, by the way, that while many pieces of PMPRB were overhauled, it wasn't just modernizing, it was overhauled. The actual definition that PMPRB uses for R&D investment was not touched. It took Statistics Canada and its report back in May to provide much more current data than what PMPRB uses from its 1987 definition.
My next question maybe for Ms. Little. You know, I'm the father of a diabetic, so I sort of have some of the same problems where right now he's on my plan, but as he ages out, he needs to find employment. He needs to be able to work through his disease and be able to get some kind of coverage. Just maybe you can explain your daughter's disease a little bit more as well.
Mm-hmm. So Olivia, it's genetic, and she also lives with chronic kidney disease, and so yeah, I'll leave it, Mr. Chair. Go ahead.
Okay, thank you.
Oh, you can finish your answer if you like.
Okay. She lives with chronic kidney disease. So chronic kidney disease is a lifelong circumstance until it leads to a kidney transplant. So on top of the cystinosis, which is what the high cost drugs treats, she has a lot of treatments that cover the renal and that aren't covered under even things like OHIP Plus doesn't cover somebody like my daughter. So there are ongoing worries that we have. Thank you.
Thank you. Thank you, Mr. Dantemont. We'll go back now to Ms. O'Connell. Ms. O'Connell, please go ahead. 5 minutes.
Thank you, Mr. Chair. Mr. Chair, like earlier in the debate, or sorry, earlier in the meeting in the first panel, we heard about some testimony regarding the PMPRB being asked to appear, but I just want to correct the record while I have a chance that it was actually the PMPRB was only invited yesterday, and that my understanding they would actually be happy to appear. And I think it is actually important, given the testimony we heard today in the first panel, that we do invite the PMPRB. So with that being said, I move that the Standing Committee on Health hold an additional meeting on the Patented Medicine Prices Review Board guidelines, and as we were initially scheduled to do, in place of one of the meetings to be scheduled during the regularly scheduled meeting slots prior to the end of day on June 21st, 2021, and that the clerk invite the PMPRB to appear as a witness, that the meeting take place for 2 hours, and that in addition to the PMPRB witness, each party be allowed to invite one witness for this meeting on the Patented Medicine Prices Review Board's guidelines.
Thank you, Ms. O'Connell. I find that this does directly relate to the business at hand. Therefore, I will it in order. I see that we have Ms. Frempel-Garner with your hand up. Please go ahead.
Excuse me. Thank you, Chair. I will note that the Liberals wasted 2 meetings filibustering our programming motion earlier this week. They also wasted meetings in September filibustering this. We did want to have more meetings on PMPRB. So, you know, it's just, I think this is one of those things where the Liberals putting it forward because we did lose meetings. And for witnesses that are here today, that is what happened. I will note that the meetings that are trying to be replaced in this motion allow any political party to put forward any witness that they want. So if there are additional witnesses on any particular topic, political parties can do that. The other thing is I will note that I did try to get the regulator in front of committee today. We asked for anybody from the regulator to show up and they declined. So I think this is theater. We have a motion set. I deeply appreciate the testimony of the witnesses, particularly Ms. Little. I thought that your testimony was very compelling. At the same time, I also would note that it was the members of the Liberal Party that wasted 2 meetings filibustering a programming motion, which they didn't have any substantive amendments to. The amount of heavy lifting that went on behind the scenes between opposition party members was enormous. And I just, you know, we could have had another round of questions today. So I will be voting against this motion because we literally just spent 3 meetings going through a programming motion that could have been condensed into 5 minutes of debate. So, no.
Thank you, Ms. Frempel-Garner. Monsieur Thériault, allez-y, s'il vous plaît.
Mr. Thériault, go ahead, please.
Oui, excusez-moi, monsieur.
Yes, Mr. Chair. I wasn't sure if my name had been called, but I imagine you called on me to speak. I'm rather surprised by my colleague's proposal. I remember a meeting where she thought it was inappropriate, if you will, to use a neutral term, which she doesn't often do. She thought it was inappropriate to interrupt a meeting with witnesses. She knows how much I care about this issue. She also knows, and I don't think she's given me her time, she also knows that the rules mean that I have very little time to ask questions, 8.5 minutes, whereas her government has many minutes. And she just took away my opportunity to use those 2.5 minutes when we had agreed around this saga to organize our upcoming work. We had agreed on a plan to go forward. We had reached a compromise to have a 3-hour meeting so we could give directives to the analysts so that we can have some recommendations before the July 1st date. Unless she tells me today that the government is pushing back the reform slated for July 1st, unless she tells me that, what she's doing means that we might not be able to do so. But I've already made that compromise. I proposed this study, so I don't understand why she is doing this. The PMPRB reform and the PMPRB, we've heard from the beginning, and it's taken up our time during these meetings. I have a hard time expressing the lack of specification regarding different testimonies, so I'm very surprised by what the Liberals are doing today. I see it as a lack of respect towards me and the witnesses who are here today. I find that very unfortunate because I've never lacked respect towards anyone around the table. I'm very disappointed, and I will remember this.
Merci, Monsieur Thériault.
Thank you, Mr. Thériault.
Well, I'd like to add my voice very much to what my colleague Mr. Theriault just said. Again, the Liberals last week were extremely opposed to a motion that was being made while we still had witnesses here and lectured all opposition members on that. And here they are doing the same thing. I don't know why this motion couldn't have been left after we heard from the witnesses. It would have been easy to do that. Number two, just this week, we had a meeting on Monday of our subcommittee on agenda to set the agenda. On Wednesday, we had a Section 106 meeting to confirm the agenda. We had 2 full meetings this week, hours in length, and the Liberals never once made any indication that they wanted to have another meeting. They had every opportunity to call the PMPRB to this meeting if they wanted. We had 8 witnesses. Each party was entitled to call any 2 witnesses they wanted today, and the Liberals did not. Incidentally, and as my colleague Ms. Reppel-Garner said, we have 4 more meetings coming scheduled where each party has the opportunity to call any witness they want at each of those 4 meetings. In one of the meetings, they have 2. So the Liberals could easily call the PMPRB if they want at one of those meetings. So this motion not only is insulting to the witnesses, not only has robbed Mr. Theriault and myself of our chance to ask our final. I also only have 2.5 minutes to go with Mr. Theriault. And so we've been robbed of our chance after Liberals got their time. And all for what? All to call a witness that they could have done for today and can do in the next month, or the next 3 weeks, I guess, at this point. That's unacceptable conduct. It's disrespectful to the witnesses. It's disrespectful to the members of this committee. I'm not sure that I think this is in order. I've received no notice of this meeting. We're not in committee business. It would be nice to if the members of this committee would serve notice as the other ones were. I remember last week when the Conservatives submitted a motion on the Wednesday for the Friday. The Liberal members of this committee didn't think that was acceptable. Well, I just got served notice of this 5 minutes ago, orally. I don't think this is appropriate conduct. And again, I would ask my honourable colleague to withdraw this motion. And if she believes that the PMPRB is an important witness, then use one of their witness slots that they have in the next 3 weeks to call them.
Thank you, Mr. Davies. Seeing no further hands raised, we can call the vote. And actually, if we do this quickly, we will have time for Mr. Theriault and Mr. Davies' testimony, I believe. So I would ask the clerk to call the vote on this motion.
Ms. O'Connell?
Yes.
Mr. Kellaway?
Oui.
Mr. Pawlowski?
Yes.
Ms. Sidhu?
Yes.
Mr. Van Wijnen?
Yes.
Mr. Falk?
No.
Mr. D'Entremont?
No.
Mr. McGuire?
No.
Ms. Reppel-Garner?
No.
Monsieur Theriault?
No.
Mr. Davies?
No.
So, Mr. Chair, we have 5 yeas, 6 nays.
Thank you, Mr. Clerk. So the motion is defeated. I will carry on with the questions. Monsieur Theriault, allez-y, s'il vous plaît. 2 minutes et demi.
Mr. Theriault, 2.5 minutes, please. Thank you, Mr. Chair. If I've understood correctly, Ms. Fralick, you want a delay. You want that July 1st date pushed back, and you don't want it to just be a delay. You want there to be a working table with different partners. I named a few of them earlier, and in response to Monsieur D'Entremont, you mentioned some. You've also raised the lack of consistency from the government between recommendations in the 2018 report from Economic Development that desire to stimulate the innovation and biotech sector, and a reform that's only under Health Canada that, as Ms. Perreault said earlier, has a siloed vision when we need a broad understanding of life sciences and to act at every level. So I imagine what you hope for is the creation of a working table. But would you make the compromise of having a gradual implementation? That is to say, we go forward with the country reference list, which seems to be a concession that I've read in a number of briefs. And then that's established, and then we sit down to look at the rest of the points that are being considered. Would you agree with that proposal?
Thank you. Through the chair, I think that that would be a good departure point for the discussion. And so if we can get to that table with the appropriate government officials and whoever else should be there, we can determine that, then I think that as a point of departure would be very, very useful and generate a great deal of good discussion.
Dans certains mémoires, j'ai...
In some briefs, I saw that changing the basket of reference for countries could lead to savings of 20 to 30% according to the brief. Would those be the same numbers for you? Is that realistic?
Yeah, the figures, there are several figures floating around. The first estimate by PMPRB, by the government, came in at about $8 or $9 billion over 10 years. They readjusted that. It went up to $13 billion. An independent third party did another assessment. It's about $19.8 billion over 10 years. So yes, the basket change alone would save considerable dollars and resources for Canadians.
Merci, Monsieur Thériault.
Thank you, Mr. Thériault.
We'll go now to Mr. Davies. Mr. Davies, go ahead, please. 2.5 minutes.
Ms. Freilich, we've heard, and I think we all have an imperfect understanding of this, but there seems to be this very curious way of drug pricing in Canada where drug prices publish astronomical list prices that nobody actually pays. And then the pharmaceutical companies negotiate behind closed doors significant discounts. We've heard at this meeting between 50 and 90% that nobody ever can find out. Can you explain that as an industry practice and explain if you think that's a wise way to come to pharmaceutical pricing in Canada?
Yeah, unfortunately, as an association representative, I'm not privy to the individual negotiations that take place between companies and governments.
Well, that's the problem. Nobody is. It's not just with governments. It's with insurance companies.
Yes, private payers. I should have used more appropriately. And so I just don't have a line of sight on that. Unfortunately, can't help you.
Well, the reason I ask is that it's not just an issue of expanding compared to countries. I don't think anybody can argue that expanding the present system, which has I think it's 5 to 7 countries with to the expense of 2 and 11 country comparison, that's much more representative. But also, aren't there fundamental issues of transparency? I mean, how do we set appropriate price in this country if pharmaceutical companies are negotiating secret agreements and then any attempt to shine a light on those so that we can find out what actually is being paid is being resisted by the pharmaceutical industry? Who benefits from having private secret prices paid when drugs are such a public necessity in this country?
Yeah, and pardon me again through the chair, you're dealing with commercial sensitive issues that as an industry association representative, we don't have guidance, policies, best practices that direct how payers and companies deal with this. But understanding that this is a tension, I think that if we were to get to a table, this is another point that could be discussed.
But I think that's the point, is that it's not just a private commercial transaction. The public grants a patent to private companies who then have 20 years of protection. And someone has to protect the public interest in this. Otherwise, I guess a pharmaceutical company could say, we want $1 billion a pill. And if you don't pay it, we're just not going to make the drug available. That clearly can't happen. I'm going to go to Ms. Little for my last question. Ms. Little, should we proceed with this PMPRB changes, and what would be the impact on your family and your daughter of those reforms going ahead?
Yes, I do believe that we need to move forward. They might not be perfect, but they're progress, and that's what we need. And as patients, I answered your question, Mr. Davies. I just want to say one thing, is that as a patient, and Mrs. Rempel-Gardner, I appreciate you calling my testimony today compelling. I'm not here to be compelling. And I too run an organization. And sometimes I feel I am dismissed because I tell a story. But I tell the story of which everybody at this table serves. We are the customer of this product. Somebody once said to me that our story is a bit like being suddenly cast adrift in a vast and stormy sea in a lifeboat surrounded by unmarked ships that are being piloted by either the Mexican drug cartels or the Coast Guard, but there's no way of knowing which is which. And sometimes that's how we feel as a government, with government on one side and pharma in the other, and even with the advocacy space. We need to know that we are being supported and that our children and our patients are being protected. For this reason, I do feel we need to move forward. Thank you.
Thank you, Mr. Davies. Well, thank you to the committee. Thank you to all the members for all your great questions. And thank you certainly to the witnesses for sharing with us your time today and your expertise in helping us with our study. With that, I believe our business is done today, so I declare the meeting adjourned. Thank you all.